Morning, everyone, and welcome to the Mental Ill Health and Co-occurring Issues Explored workshop. This workshop's been provided annually since 2010, and it aims to connect you with local providers as well as providing you with knowledge and skills to better manage complexity in your work with people. I'm Bronwyn Williams, and I'm the Eastern Mental Health Service Coordination Alliance Coordinator. And on behalf of all the presenters of this webinar today, we acknowledge the traditional custodians of the land on which we meet virtually. For me and my team, that's the Wurundjeri people of the Kulin Nation. And we pay respect to Aboriginal elders past, present and emerging, and to Aboriginal and Torres Strait Islander people joining us online today. Also, EMSCA recognises those individuals and their supporters who have a lived experience of mental ill health and the important contribution that they make to the development and delivery of health and community services. You'll have the details of the Slido application now. So to access Slido, simply search for Slido on your phone. The event will be much more useful if you get the Slido app up and start using it, so please do. You just use your favourite search engine, put Slido in on any device and you'll find it. And once you reach the Slido page, you don't need to sign up or anything. You just need to put the code J300 in and you should be able to see the polls and the Q&A functions. And in Q&A, you can ask a question at any time during the event, and you might also like questions like you would on Facebook, post by other participants. And in this way, we can prioritise the questions to be answered. Ruben Sago is our moderator for the Q&A, and he'll be activating your polls today. So our first poll is designed to help everyone know who's in the room. Please answer in a word, which health or community service sector do you represent today? For example, mental health, homelessness, family services, AOD, NDIS, etc. And we can see that some people have already got in there and answered the poll, so thank you. This is just a good way to connect when we're in a virtual world to know who's actually with us. So it looks like we've got a strong group of mental health staff and AOD. Homelessness is prominent too. It's good to see some dual diagnosis in there, domestic violence, disability employment services, NDIS. And so there's a couple of homelessness there that haven't been included in the homelessness one. So there's obviously quite a few people from homelessness. Services Australia. So that's what we would have thought of as Centrelink in the past. Terrific. Some local council and Aboriginal community. Welcome. All right. So moving right along. Thank you. Thank you for participating in the poll because that was really great. And I've got this. Brad, can you just advance the slide for me? Thank you. So this event is a two-part series and you'll have details in your booklet that I emailed you on Tuesday. You'll also have the slide pack. And we're recording the first half of today's session and this will be available on the EMSCA webpage later in the week. The second part of the session we're not able to record. We have three engaging and knowledgeable presenters for you today. Elf will provide you with some guidance about how to approach complexity from her lived experience perspective. Dr. Tarak will speak with you about mental illness and intellectual disability, and Kathy will work with you regarding how to approach the complexity of acquired brain injury and mental ill health. And as we will break out into groups, we've assigned staff to facilitate the discussions. You will be assigned to rooms at 2 points in today's webinar, and when this occurs, you will not need to move yourself at all. Just allow Brad Every to move you around. Brad is our technical facilitator. If you're unsure of any acronyms or terms, please feel free to ask in your small group. Someone's bound to know the answer. And the EMSCA Implementation Committee is responsible for the development and delivery of all EMSCA events, including this one. Here's a list of all the people involved in providing the webinar today. And I just want to note that 12 months ago, November 2019 was the last time EMSCA was able to hold a live event. So we welcome you to our online version. So the EMSCA Implementation Committee members, Brad, you might just need to go back to the slides just briefly. The EMSCA Implementation Committee members are all part of this multi-level alliance. Here are the alliance partner logos, and you may see your logo on this slide. EMSCA aims to strengthen mental health and AOD service collaboration, coordination and system integration across inner and outer eastern Melbourne for improved consumer outcomes. So it is time for another Slido poll. So what is the most common co-occurring issue, not mental health, that you come across in your work? So not mental health, but any other co-occurring issue that you come across in your work that you think is the most prominent. We've got risk of homelessness come up nice and strong. Terrific. Family violence, AOD. Disability and AOD.
You type that in. How do you type it in?
Just type it in. There should be a keyboard on your phone.
Oh, I'm on the computer.
Oh, on the computer, just use your keyboard if it's connected.
That's it.
Did it work?
I don't know, but it's already there, so that's good.
Awesome. It probably did then. All right. So it seems like AOD and family violence are the strongest in this here. We've also got corrections, ABI, trauma, homelessness, and grief. Okay, that's a strong one. Grief, co-occurring grief. Very good. All right. Well, that gives us a really good sense of what we're looking at. Now, this workshop is going to be addressing a few co-occurring issues, and certainly next week we'll be looking at AOD and mental health as one of our topics. All right. Now, one of my problems is that I have this special clicker on my phone. I'm going to tell you about my technological thing because it times out every now and again. So that's why I've been looking down. All right. So moving right along. It's been long acknowledged that people with complex needs often fall through the cracks in service delivery. Between federal and state service delivery, between government and non-government services, and between services delivered by different agencies. This event aims to support you to work effectively with a range of complex issues as we work to prevent the intra-service gaps in support. So now I'd like to introduce you to Elf Walpole, who's a lived experience consultant, often working with Nemo National. Elf's an artist and a mother of 5 who's been engaged with partners in recovery in the past due to her complex support needs along her personal journey. Elf will introduce our workshop topic as she shares her advice to service providers today.
Hello, fellow participants. My name is Elf. I invite you to take this time to hear my words and see through the lens of my experience as a consumer. I thank you for your attention and thank Nimai for the privilege and honourable opportunity to bring increased efficacy and long-term investment to the great work of these immeasurably valuable support services. With a feeling of great responsibility, I will attempt to highlight some important points for your consideration. I'd like to offer my insights in these key areas: respect of privacy and trust, goals, advocacy, language, managing overwhelm. To begin with, I shall start with respect of privacy and trust. Having a support worker who offers a little personal reference can bridge the roles gap. Consumers are painfully aware of a power balance and can feel uncomfortable with a one-sided relationship. Finding relatable ground with each other can improve trust and disclosure and build a common language unique between you. So I can feel more normal and closer to achieving my goals. Acknowledging that we all have challenges and need support in different areas, not having these support structures to navigate life or the trust to reach out may come from very real and complex experiences and not just an unwillingness to try harder. Feeling judged makes it hard to reveal key areas of your support needs. Some goals may be in the too hard right now basket. But as the smaller items are achieved, it promotes a confidence template. Consumers may withhold due to fears that if they reveal certain things, they may have an unwanted intervention. It's really important to accept that what you may like to offer from a clinical solution base may not be timely, and timing is really important. But trust that your consumers will build towards that as they gain more stability and order through your support. Some of the unhelpful habits may be coping mechanisms that will evolve naturally into a more conscious self-care mindset. Being aware that each person is unique and can only make so much change in the time that you have to offer your support. But practice builds momentum. Goals. One of my own needs was to build my confidence back up. I knew I had become estranged from myself, and I knew I couldn't go back to find myself. I had to go forward and accept building a new version of me. Having a person to share that journey with in its infancy is a very powerful mutual relationship. I felt an innate human respect right from the beginning and consistently throughout my engagement with Nimai. They seem to provide the missing piece. Having the opportunities to be a consumer consultant and assist with interview panels gave me a real boost. It reached into every aspect of my life, and being valued and heard was so important to me. When that resource is lacking in my life, I can lose myself to depression, self-destructive choices, and poor self-care. Whatever can be done to provide a sense or role of significance for your consumer will have a cascade effect. For me, it was a community work for a local group I got involved with, and the roles with Nimai National. This has championed my natural talents and the practical opportunity to engage meaningfully in the community with sensible strategies and courage. How can your suggestions and strategies engender ownership? Goals. Using your skills in researching, you can bring some key starting points as suggestions to consumers. I found motivation to push through my perceived barriers in the collaborative approach, choosing together actions I could take to gain confidence and a sustainable goal-setting strategy. Bringing my good news to each meeting built self-esteem and rapport, breaking down tasks into stages and doing what I hated first, believe it or not. Having a little reward afterwards and shooting off a message to say I'd done that. I was really, really thankful for a message back acknowledging it. It meant so much. Advocacy. Having offers for advocacy is really important for appointments, with the emphasis as being a coach before in the preparation stage, getting paperwork in order, and a reminder the day before by text. Being prepared to sit back and let the consumer lead, and also be there to prompt them or to ask to add something that may have been missed. By giving a brief reminder, you can encourage the consumer to take over. Also, to gauge possible overwhelm and negotiate a break or a chance to regroup. Language. This can be very off-putting. When a support worker uses a lot of institutional terminology, sensing if your language has been understood and is giving clarity or not is really important. It can be so intimidating to ask, but there will be detectable clues to know if you have lost understanding. Be dependable and organised with notes so you can make use of limited time. Managing overwhelm. Bringing order to my life. Sharing that responsibility, and humans need support. These are my points. You have valuable resources and skills to access a network for getting on top of the most urgent unmet needs. When you bring your insightful perspective and fresh energy to these tasks, it takes a lot of pressure off your consumer, making space for them to get out of survival mode. If you can convey the sentiment that anyone can experience overwhelm and feel paralyzed, that this is typical of having a complex life experience, that they tend to layer up exponentially too, without support, is really understandable that one may not cope. Also, it can be a real struggle to find that support and build a way to stability. A sincere offer to share that responsibility until a variety of sustainable external resources are found and inner resources are restored are key to success here. No matter who we are, what we've experienced, a common denominator is our need for a support team. Building that with my support worker was a huge help. Some of us have lost that for a variety of reasons and feel unable to be worthy or even know where to start in the rebuild process. Feelings of exclusion and isolation are core areas to be aware of. In a competitive world, the gap can appear immense. We all need to have something to give, and losing connection to our own value can be like feeling invisible and unworthy. Complexity. I feel there are some misunderstandings around complexity. To be honest, is it the person or the factors that they're experiencing? I feel that people are actually pretty simple and their needs are pretty simple. The problem arises from having multiple challenges. For example, undiagnosed physical health issues, traumatic experiences, maybe multiple ones. The lack of personal resources to carry these without a support network can bring a person into absolute overwhelm, and rightly so. Adding the difficulties in accessing targeted support in a timely and well-targeted way can destroy the trust and belief that there is any help that will make any difference. My story with fibromyalgia and depression that was related to chronic pain was a complex one because I was continually going to doctors and describing my symptoms, but I never got a referral to a specialist who would therefore have an answer and a diagnosis to help me manage and move forward. Instead, I was told that I was just tired and I needed a holiday. This was very unhelpful and really just added to the strain on my mental health. I also had waited quite a long time for my diagnosis of complex post-traumatic stress disorder. I had some very early and intense childhood trauma, and I missed out on support for many decades. I had lots of coping mechanisms, but by the time I was 40, I really needed support. And thankfully, I was able to reach out and find someone to work with, and that has helped me so much. I'd like to draw attention to one of the biggest barriers to a productive and genuine consumer-provider relationship. Wrong assumptions. They will always be noticed. They will always destroy trust, and they will always erode hope in recovery. But they can be fixed, and they must be identified and fixed. I would like to ask you to cultivate an open-minded, curious, and prepared to learn from each consumer approach. Thank you for your time and blessings from my heart.
Thank you, Elle, for your enlightening advice about approaching complexity in our work. Here's a list of the keys to approaching complexity that Elf provided today, and you'll find these in your slide pack too. This is just to help you keep track of the things that she was sharing with us. Now we have Dr. Tarek Albaruz presenting the first workshop on the topic of intellectual disability and mental ill health. So quite different complexity. And I'm going to invite Dr. Tarek to start his camera now. So Dr. Tarek Albaruz is a consultant psychiatrist working at the Victorian Dual Disability Service, and he's a fellow of the Royal Australian and New Zealand College of Psychiatrists and a member of the UK College, Royal College of Psychiatrists. So please make him welcome today.
Thank you so much, Bronwyn. Can you all hear me all right?
Yeah.
Excellent, excellent, excellent. So thank you so much, Bronwyn, for the kind invite. And today we will talk a bit about intellectual disability and mental health, and a bit about the complexity related to the assessment and the management. This is basically just to give you a general overview of the management of patients with intellectual disability and comorbid mental health issues. So I would like to start first by explaining a little bit about the Victorian Dual Disability Service. So basically we are a statewide service for mental health of people with neurodevelopmental disorders, including intellectual disability and autism. We see patients from the age of 16 upwards, no upper limit, and referrals to us are basically just a phone contact to the number provided. We do usually assessments to provide to clarify the diagnosis or advice on the management, but unfortunately we do not actually manage or treat patients. We provide a range of other training and a bit of research, and our cohort is usually referred by the local public mental health service. And we also do have some funding to provide limited number of assessments for patients engaged with NDIS. Now, let's talk about mental health in general and mental health in people with ID. So in general, mental health in general population is quite a common problem. It's about 20%. And in the population of intellectual disability, it's actually double that. So it's actually about 40%. And it depends on which study you look at. It can actually increase up to 70 or 80 even percent. Now, with that common problem, there are a lot of difficulties with mental health assessments in people with intellectual disability. Some of it basically relates to the high rates of often the undiagnosed or inadequately treated medical problems. The mental health presentations and needs of this cohort is usually complex and enduring. And with the difficulty or with the difficulty of communication and engagement, that leads to complication with identifying an atypical presentation. And we also know that within this cohort, sometimes the response to treatment is usually, can be at times unpredictable, take longer, and they are more prone to side effects or even paradoxical effect of medication. So assessing and managing people with a dual disability usually needs more time, more contact, and more patience. So let's have a quick overview of how patients with intellectual disability and comorbid mental illness present. So when you look at them in a cross-sectional manner, usually you see a lot of organic issues, mental health issues, and developmental issues all interacting with each other that actually give you the common presentation. So most of the clinicians usually are aware of these issues. However, if you look deeper, you will actually find even more factors contributing, that personality issues, drug and alcohol, behavioral issues, and they all together basically present usually contributing and interacting with each other at the same time. So that makes the presentation quite complex. However, when you want to assess and manage such complexity, you need to have a hierarchy in approach. You cannot actually disentangle all those things at the same time. You need to basically think in a kind of more of a hierarchy approach. And with that, I would suggest using this model, the Falls hierarchy, where you start by looking into and ruling out any organic issues, and then go through drug and alcohol, and then you go and think about mental illness, particularly psychosis, and then mood disorders, and then anxiety and OCD. And whatever is addressed and left after that, you could contribute it to behavioral factors, personality, or autism and intellectual disability. All these factors are considered patient factors, and we all know that patient factors do not exist in vacuum. You also need to consider the wider picture, the wider issues. And within that, there are a lot of environmental factors, systemic issues, legal factors, and professional factors that they all interact with the patient factors that lead to either improving the situation or making it even more complex. So I know it's a lot to take in, but I will break it down again with giving you some kind of a framework, a suggested framework you can use in assessing and in managing patients with dual disability. So when you want to approach the assessment, usually in mental health, the suggested approach is biopsychosocial. And when you're dealing with a dual disability, I would suggest also emphasizing the developmental part. So think about biological, psychological, social, and developmental aspects to the assessment. And that will help you to better understand the presentation, better understand the person, and pick up on any acute changes. So with the assessment, there are special considerations that you need to take on board. First, you need to assess capacity to consent. When you engage with a person to assess them, you should not assume because of their intellectual disability that they don't have capacity to consent. It needs to be considered. It needs to be addressed. Do they have capacity? Do they consent? If they don't, then what legal framework you are using to basically proceed with the assessment. You also need to consider communication and engagement. And the best way to do that is basically to get to know in advance, before you actually even approach the assessment, to basically know what their usual communication skills, what their usual abilities. Do they use any particular form of communication aids? Anyone else can be involved in the assessment process to help and aid the engagement and the assessment. You also need to emphasize collateral information from different sources, collateral information about their development, their baseline function, their baseline behavior and presentation, what they can do, cannot do, before all the difficulties started, what other developmental disorders they have, what physical health issues they have. All those would help you to establish their baseline and give you a guide about how things are evolving. And after actually formalizing the problems and then providing a treatment, that will help you also to give you feedback whether your approach is actually helpful or not. There are certain behavioral phenotypes associated with specific genetic disorders. In the collateral history, you need to be aware of that, because that will help you and guide you about what's the baseline behavior, what are the expectations and prognosis and future difficulties and prognosis as well that you need to address. There are, and we discussed the developmental history, and there are some pathoplastic effects of developmental level. So you need, again, I keep repeating myself, but it's quite important that you get a very good developmental history, because that will help you to understand their abilities, their behavior, at what level and what stage of development they are at. And that will basically give you a clearer picture, because sometimes when people with intellectual disability, sometimes they have what we call it overshadowing, diagnostic overshadowing, where we basically assume and attribute everything that they do, all the difficulties, all the issues, to basically their intellectual disability, ignoring the fact that they are more likely to develop mental illness, they are more likely to have other health issues, and that can basically be blinding to us, that we just attribute everything to their intellectual disability. Also, sometimes if we don't have a good understanding of the developmental level, not their chronological age, but the actual developmental level, we can actually misinterpret some of their symptoms. For example, if a person, for example, is exposing themselves in public, we may misinterpret this as a form of disinhibition, while in fact it may be that they actually at the developmental level where they don't actually understand that this is not, socially unacceptable. We also can sometimes apply our own, social expectations. And, if the person, for example, say, I want to be a pilot or I want to be a bus driver, and if we apply our own standards, then we consider this as, normal ambition. Well, in, at times, if that is actually way over, not possible, and the person already had the insight to understand that these are not possible, and they suddenly started to believe that, it may actually give a hint that this is a grandiose delusions. Physical health and classification issues are also other complicating factors in the assessment process. They have a lot of physical health issues, and that needs to be taken into consideration because it can actually present with behaviors of concern or lead to mental health complications. And with classification issues, here it's important to know that the golden standard classification methods we use, whether it's ICD-10 or 11 or DSM-4 or 5, those classification systems were actually not designed to basically diagnose mental illness in people with intellectual disability, particularly those with a severe form. Hence, there need to be some flexibility in how you actually apply those criteria and look at the bigger picture when you apply those criteria. Now, the key question when you are trying to assess a person with dual disability is this problem new or chronic? Or is it acute on chronic? So basically, you need to compare the usual behavior and the usual function of the person in all areas before they present to you. And that will give you a good idea about what's their baseline like, and any change in their function, any change in their behavior. And that change can range from basically just an increase or change in the location, severities, who it happens with, or a complete emergence of a new behavior. All those are considered as acute changes, and they usually indicate that there is a problem. It does not indicate automatically that they have a mental illness, but it indicates that there is a problem that needs to be investigated and addressed. Mental health is part of it. Mental health is possibly one of it. Now you are all expert in assessment. We will move on to general principle of management. So again, I'll give you another general framework on how to approach the management. And basically that goes first to a consent and legal framework. Again, the same principle. You need to basically assess, does the person have capacity to consent? If not, what legal framework I'm using to address that issue, and who else is providing consent? After that, you need to manage risks before you actually can disentangle what's going on, because sometimes, as we've discussed, the assessment can be very time-consuming, involve multiple professionals from different services, and that can take time and process. However, risks are acute sometimes, and they need to be addressed first before you actually disentangle what's going on with the person. And managing risk, that includes, you need to think about, is this person safe where they are? Are the current supports and services involved appropriate? Do I need to approach other services and involve other services purely to maintain safety while we, figure out what's going on? And then after that, you go back to the hierarchy we've discussed, where you go through the organic and mental health and the rest of it. And sometimes it's not crystal clear what's happening. Once you rule out organic issues, that's the most important thing after risk management. But then sometimes the diagnosis is not very clear. And with that, you need to modify your approach. And instead of basically saying, well, I couldn't establish a mental illness, hence, and I'm not going to get involved, it's the other way around. It says basically you need to actually basically think about, okay, so the acute changes involve 1, 2, 3. I will have a very clear goals of treatment. The goals of treatment can be treating a well-established mental illness, a suspected mental illness, or a change in the presentation, change in the behaviors. And with that, once you have a very clear established goals of treatment, you need to have a baseline assessment of severity, because this will be the benchmark where you will basically start treatment based on your formulation, and you always follow it up and refer back to it as, are we heading in the right direction? Are we helping, not helping? If helping, that basically confirm your formulation, and you keep doing what you're doing. If it's not helping, then you go back and reformulate and come up with new strategies in helping the patient. And the most important thing is to follow up and monitor the procedure. The approach to management, the framework, again, biopsychosocial, but here, instead of developmental, like in the assessment, here we emphasize environmental. So biopsychosocial and environmental approach. You need to address every and each one of those. And always think of comorbidities. Think of the first couple of slides. Usually they present with a multitude of different things happening at the same time. If you address only one thing, usually you will have limited response, because you're not actually addressing all the other issues contributing to the problem and feeding to the problem. And that can be a bit misleading sometimes, and can be a bit leading to burnout. I'm doing all those things, but it's still not working. The person is not well yet. And hence you need to basically take a step back and rethink about your formulation. Now, I would like to introduce a case. The case has been de-identified, and we will call him George. So I'll give you a quick, brief summary of it, but you can also, after we break down, you will have all the details in your booklet. And I would like you to think about this case and consider a few questions. First, is this presentation resulting of intellectual disability, autism, mental illness, organic, or I don't know? And we will have a poll of that, and also would like you to think about what adjustments you would need to do to your practice when working with George, and which services need to be involved. So basically, George is let's say 23-year-old male with background history of chromosomal abnormality. Associated with that, he has intellectual disability, roughly IQ of 55, autism, epilepsy, and a long-standing history of behaviors of concern. And 4 years ago, he had an episode of acute escalation in the behaviors of concern, leading to admission to the hospital, where he was suspected of having bipolar affective disorder mania. He treated, he settled, and after that, he was discharged on a mood stabilizer and antipsychotic. Recently, his epilepsy settled, and his mother stopped the mood stabilizer, and that coincided with 4-week history of escalation in the behaviors of concern. He presented with agitation, aggression, not sleeping, spitting at his parents, and not focusing, and a lot of aggression towards property and others. That led to basically safety concerns, and he was brought to emergency department and hospital. So I wonder if we actually can do a poll now, just to give your, brief what you think the problem is, and then we will break into groups, have further discussion, and after that we reconvene and discuss the case in more details. So what do you think is going on? So far, 100%, I don't know. 50-50 autism. And I don't know. It's rapidly changing now. Excellent. Okay, that's brilliant. Come on, don't worry. There's no right or wrong answer. It's just your impression. So now intellectual disability, mental health, and I don't know, all equal at 10%, autism 36, organic 32. Okay. And roughly half of the participants complete 22. Okay, excellent. So now I think, great. So now we will break into groups and have a discussion about the case. You already have a lot of other details, and at the end we will reconvene again. And it would be great if every group has you know, a spokesperson to just basically give us some ideas and insight into what discussion you had, what adjustment you would do, and the services. But before that, we also will do the poll again and compare the result. Okay, excellent. Okay. No more voters? Okay. Okay, so it seems like the consensus is, can we go back to the vote results? Yeah, so organic causes seems to be the top before and after the discussion. Autism, I don't know, intellectual disability, mental health, all come second and with a big margin. Excellent. Okay. Now, before we discuss the case, I would have liked to see more of I don't know, because many you know, a lot of the information are not included in the presentation you got, and that was intentional. So I provided you with almost 2 pages of information. However, there were a lot of things missing from those information. So we don't actually know about his baseline function. We don't know much about his baseline behavior. We don't know much about his baseline medical and mental health issues. We don't know about his previous presentation of mental illness. And based on that, I'm happy that the majority said the likely main issue is organic, because definitely that needs to be excluded first. However, I would have liked, I don't know, a bit more. But anyway, organic, I'm very happy with that. I'm very happy with organic. But I'm not suggesting that this is what's happening. So the next stage now is to basically discuss the case in a bit more details. And with that, do we have presenters or spokesperson from each group, just to tell us a little bit about the discussion, what they come up with, and what adjustments they would like to make before I give you more details about the case?
Yeah, I'm happy to discuss what our group talked about.
Excellent.
We decided that we didn't have enough information to really know what happened, and we talked about, you know, the psychosocial baseline, and that was a really important aspect for the group, was to establish his baseline and what had happened in the past. And then I'll just make it quickly, because there was a lot of, you know, what could possibly be the trigger for this new onset of behaviours. And so that would be doing a lot of investigation, really. And then we moved into the organic, and we talked about how it was really important, the language we used with George, and sort of establishing, because another thought was we don't want to just be referring him off to multiple agencies and putting him under that level of stress. So it was about really being mindful of the language we used and establishing, did he feel unwell? Did he have a pain in his body? And then from then, there would be a referral into the doctor to see if it was an organic problem. And there was two sides to that conversation, but I'm afraid that's as far as we got in our discussion.
Brilliant. I'm very happy with that. Excellent. And another group can add.
I would like to.
Oh, you go, Rose.
Oh, yeah. So in our group, we discuss about the adjustment to that we would make is
Yes.
we spoke about community mental health services, and given that George is already linked in with the psychologists and stuff that have so many services already involved in his life, and we're thinking having to work with family is very important, because we do find that sometimes in a treating environment, families are being excluded. So having to work with families to find out what it will work better for George would be great.
Absolutely. Excellent.
And
Very
the
good.
services that needed to be involved, we didn't get much into that because we ran out of time. But I thought, like, coming from the NDIS space, I thought NDIS would be also important. So maybe thinking the prospect of, applying for NDIS if if the family has not thought about it, something that can be discussed during the treatment, to put the supports into place.
Perfect. Perfect.
My group, you can add on something.
Yes.
If
Next
you
group.
wish to.
I'll quickly go. Similar to what Rose said around the family, working with them to potentially make George feel more comfortable. If he's in hospital, bring some things in from home. The medication, bit of a mystery. That'd be good to explore whether that's having a paradoxical effect. The idea of he's exposing himself. We suggested that could just be a way to get people to leave him alone, or it could be to do with his intellectual level. So again, without knowing his baseline, it's really hard to know.
Brilliant. Brilliant.
Yeah.
Excellent. And do you have any more groups, or that's it?
Yeah, I'm happy to contribute. Oh, sorry, you go,
Perfect.
Anna.
There's 8 altogether.
8 groups. Wow.
Look, similar to what was already been said, we kind of, went through, could be this, could be that. So,
Yes.
it could be a range of things. Look, the key things was obviously around the family. So rather than just having just services and professionals, the family was a really critical in terms of support and what's familiar. We also mentioned about the medication and considering, what's the impact of that medication on his current sort of functioning and capacity, and the impact that that's having.
Sure. Absolutely. Absolutely. Next group.
Yeah, thanks, Tarek. You'll be happy to hear that we wanted more information, first of
Well
all.
done. Well done. My job is done here. I can go home.
Yeah, you can. Thanks, Vanessa, for that. We were interested in the mood stabilizer medication recently stopping. We wanted to look more into the spitting and yelling versus the hugging and the time changes there. We would ensure that clinical case managers were involved, and we wanted a collaborative approach so that with consent, relevant risk and information was shared.
Well done. Well done. Any other groups would like to add something?
Yeah, we talked a little bit about wanting a little bit more collateral from other places, families, other support networks that might already be in place. We focused a lot on that rapid deterioration. We also coupled that with the valproate reduction, but also the organic things that were going on for him. And we wondered how that all played together. That's probably really us, I think.
Brilliant.
Can I just say, we wondered about the recent events that he was referring to, what they might have been, and also whether there had been any disharmony between his parents, because he was pushing them away and outed his father, and then the hugging, so that sort of push away and pull back in again. So we wondered whether something had happened there.
Sure, sure.
And I was from that same group with Katrin, and we also were looking at if you were from a housing service that you might be thinking about referring to mental health to get better support. So we're sort of looking at it from different perspectives of providers.
Sure.
And yeah, the relationship was a really strong one that Katrin brought up, that possibly there's something going on between the parents and that he's trying to tell us something.
Excellent. I think for the sake of time, we will leave it at that. So I totally agree with all of your comments. They're all quite valid, important, and brilliant. Brilliant. You all have been listening. Thank you. So yes, I agree with you. And as I said, it's important to know more details. It's not about how much is typed in the information. It's about the quality and the details of the specific information we're looking for. So in George's case, basically his baseline was of someone with moderate ID. He can attend to his self-care with support from his parents. His communication is usually limited to few words, and usually in the context of his ID and more importantly ASD, he usually does not initiate conversations. He usually, when he wants something, he will just pull someone to the place and use only few words. He had a lot of interests, special interests, including, listening to music and iPads stuff. His behaviors of concern were long-standing. However, they were not that severe. So usually he would have an escalation of maybe 10 minutes for a very predictable reason in the context of miscommunication, sensory issues, or wanting something without understanding that it's socially inappropriate and being told no. That at that point he will escalate with a bit of agitation. Maybe he would spit, but usually will calm down and smile and get back to his routine in 10 minutes. So also in terms of his so this change, this acute change is very marked change from his baseline. And this change also was associated with a significant functional decline. He wasn't able to attend to himself. He wasn't allowing others to actually help him to attend to his self-care. He also wasn't able to go to his day program where he used to go and attend, and his concentration was very poor. Now, in terms of his previous mental health, his previous episode carried exactly the same signature with exactly the same trigger. He was on a different mood stabilizer. He was on a different, well, carbamazepine, which was used for epilepsy at that time. And his epilepsy settled, improved, and when they stopped it, then he had a similar presentation, extreme agitation, not sleeping, exposing himself, very labile in his affect. 1 minute laughing, 1 minute he's crying, 1 minute he's hugging, 1 minute he's actually spitting and aggressive. And he got admitted, and they thought it was maybe related to his epilepsy, and they checked his epilepsy and it wasn't. So they started him on an antipsychotic and a mood stabilizer, and he settled. However, he was lost to follow up. And then there was a bit of confusion because it was the first episode at that time. And there was a bit of confusion whether, mental health service believed it was bipolar, they probably miscommunication somewhere. The family got it as it's for epilepsy, and continued with that and stopped the antipsychotic, continued with the mood stabilizer. And then later on, when the epilepsy settled, the mother stopped the mood stabilizer, believing it's for epilepsy. And he had exactly similar relapse with exactly same signature. However, you are all absolutely right. We still need to rule out organic. So he was admitted. He had MRI and EEG, and one-to-one monitoring didn't show any evidence of seizure activity. He was put on a lot of medication and he improved on it. And when they started to reduce it, he escalated again. At the same time, that coincided with having tonsillitis, but they tried again a different medication and it didn't work. In terms of what happened afterwards, he received ECT and perfectly fine afterwards. What adjustment we need to make in approaching this case? The adjustment is basically communication. We need to understand, we need to communicate and get all these details from previous assessments, from the family. What is he able to do, not able to do, how to communicate with him, how to engage with him, and all the basically the special interests that he has. In terms of which services that needs to be involved at this point, he needs to have a good organic workup, including the involvement of a neurologist, to see whether epilepsy is a contributing factor, and to rule out all other issues. He also needs mental health to basically address the acute risks and to address the mental health issues and to follow him up after he settles. The parents need a lot of psychoeducation about what's happening and what to expect and how to manage and go about all those contributing factors. And the team needs to be educated about autism, about intellectual disability, about how to communicate with him, the importance of routine, structure, sensory aspects of the environment, and all those things. After discharge, he will need a lot of support and a lot of services involved, including NDIS, communication speech pathologist for communication assessment, sensory assessment, and ongoing reviews with a neurologist and mental health, among other services. So if you think about the factors contributing to George's behavior, you'll find all those at play, and they all need to be targeted and addressed. Yes, maybe the mania at that point was the priority after ruling out organic. However, if you don't manage the epilepsy well with all these medication, it will emerge as a problem. If you don't manage the autism behaviors associated with that, he will be destabilized. So all those factors are important to be addressed. So for the sake of time, in conclusion, people with dual disability usually have atypical presentation with high rates of challenging behaviors and communication impairment, which leads to high level of complexity. With that, they also have increased comorbidity of physical, mental health, social problems, environmental problems, and all that. And interagency collaboration is vital, and reasonable adjustments can make a major difference. And that's the end of the presentation. Now, I'm happy to answer any questions you have with the remaining time.
Yeah, please just enter your questions in the Q&A function of the Slido app, please. And I'm not sure, Ruben, have we got some questions in there to be put up today?
Excellent. I can go home then.
No, not yet.
I'm already at home anyway.
You haven't got far to travel.
No. Bronwyn, do I actually have time?
Yes, you do.
Questions? Excellent. How much?
You have a couple of minutes.
A couple of minutes. Excellent. Okay. So very urgent questions.
Very urgent questions. If you can't manage Slido, pop them up quick. You have done an excellent explanation, though, I must say, Tarek, and it may be that people are blinded by science at the moment and taking it all in.
Brilliant. This is the way it should be. This is not about giving information. This is about raising your awareness of what you need to actually go out and read about and explore. And I know it's a lot to take on, but it's important to raise these issues to increase awareness.
And I think it's important. Here we go. How quickly would George cycle between spitting and hugging?
Seconds.
Okay.
Was the collaboration between services in case acceptable? Yes, this second time, they were all brilliant and they were all on board and helped to move things very quickly.
Excellent. Was the relationship between the parents explored at all, Tarek?
Yes, and it wasn't a contributing factor, at least to our knowledge. The spitting and hugging probably was a reflection of his rapidly fluctuating mood and affection, and that spitting and exposing himself wasn't usually a common character that he would spit and hug. I know sometimes it does happen in certain people with intellectual disability, but that usually was not the case. It was only a signature when he is in a relapse of mania.
Yeah. Now we've got something in the chat here about is there a list of bulk billed psychiatrists in Melbourne? To my knowledge, no.
No, and the best way to find one is to go to the college website and find a psychiatrist, and one of the criteria is bulk billing. Is there age limit to the service? Our service is from 16 upwards, no upper limit. Not necessarily what would comment on how combination diagnosis of autism and schizophrenia can. Sorry, the last word is covered. I cannot see it. Here I can affect someone. Yes, yes. Autism and schizophrenia they commonly coexist with each other. How do they affect the outcome? They do affect it in different ways. Autism. It's important again to go and understand the baseline function. What are the symptoms attributed to autism, the usual presentation, and how then things emerge with the schizophrenia? Because schizophrenia and autism, you may tend to over-treat schizophrenia with particularly when there is negative symptoms. So it's important to know where the baseline is of function with autism. So that will be your target in managing the schizophrenia. Also, the interaction between the two usually makes schizophrenia a poorer prognosis, and differentiating negative symptoms versus social difficulties can be complex. However, general principles of managing autism with structure, routine, good communication, all those factors contribute to better control and better outcome in patients with schizophrenia. But as I said, there will be a bit of issues around overlap between the two. That's a quick answer because I think I'm over my time.
That's terrific. Thanks, Dr. Tarek.
No
And
problem.
we will have a little bit more on autism spectrum disorders next week as
Excellent.
well. So that'll be great. Well,
Excellent.
thank you so much for that. That was really informative. Perhaps you want to flick to the next slide because you've got a couple of resources.
Yes. Here we go.
And Matt's saying, thank you, Dr. Tarek. He really enjoyed it.
My pleasure. So this is some of the resources, and these are other resources you can have a look at. Okay.
Thank you very much. I wish we could all applaud you. It's difficult in this environment.
Thank you. Thank you very much for the kind invitation.
Thank you. Now we're going to take a short break and we're going to be back ready for our next workshop in 10 minutes, please.
Excellent.
All right. Well, it's time to get started. We have got a little bit more time today, so that's great. And I just want to say good morning again to everybody who's joining us in Zoom. I want to welcome you all to the part 2 of Mental Ill Health and Co-occurring Issues Explored workshop. And this event is a series of short case-based workshops to enhance your skills in working with a variety of complexities. I'm Bronwyn Williams and I'm the Eastern Mental Health Service Coordination Alliance Coordinator. We call that Alliance EMSCA for short. And on behalf of the presenters of this webinar today, we acknowledge the traditional custodians of the land on which we meet virtually. For me and for my team, that's the Wurundjeri people of the Kulin Nation. And we pay respect to Aboriginal elders, past, present and emerging, and to Aboriginal and Torres Strait Islander people that are joining us here today. We welcome and celebrate diversity at EMSCA as we reflect the variety of cultures and communities we serve. Our alliance strives for true collaborative practice and a spirit of inclusivity for all. EMSCA recognises that poorer health outcomes are associated with experiences of discrimination and marginalisation, and we challenge inequities in the development and delivery of health and community services. EMSCA recognises those individuals and their supporters who have a lived experience of mental ill health and the important contribution that they make to the development and delivery of health and community services. And now you can see here how people are feeling around managing risk as part of a cross-sector group. What a good representation there of folk. All right, so today's sessions are going to be helping you to address that. Particularly Susanna's session in a moment is going to help you to address that particular part of working in a complex care team where you have multiple service providers involved in supporting somebody. So we can see that today's presenters, we have Susanna Munro, who's a complex needs coordinator for MACNI, the Department of Health and Human Services. We've got Gavin Foster, who's going to talk us through how to be a dual diagnosis clinician. And James Shelley will be introducing us to how to work with autism spectrum disorders and mental health. And Tanya Curlis, who's a clinical director at Clarabel, will be, Clarabel, I think that's how we say it. So Tanya is going to be facilitating that autism and mental health session for us. And this is our team. We have facilitators in each breakout room for you today. We've reduced the number of breakout rooms, so there'll be plenty of people in each room. And we still have the Discord link for Brad. If you're having any technical difficulties throughout the session, you can go to this link here and Brad Every will answer your questions. So now I'm going to invite Susanna Munro to come and speak with you, and she's going to help you to understand better the topic of how to manage risk as a complex care team. Take it away, Susanna, and just let me know when you'd like to change slides.
Oh, okay, great. Thank you so much, Bronwyn. Hi, everybody. Yes, I'm Susanna Munro from the Department of Health and Human Services. Some of you would be aware of MACNI. Potentially some of you may never have heard of MACNI before. I might get you to flip over slide, please, Bronwyn. Just to give you a little bit of background on what MACNI is and who we are. MACNI stands for Multiple and Complex Needs Initiative. The department designed this program back in 2004 to support the Complex Needs Act. They were finding that there were a lot of very complex clients that were slipping through the gaps, needed further support and understanding, and the program commenced. It's a joint program funded by the Department of Justice and our department, and complex needs coordinators such as myself manage the program for the department. Next slide, please, Bronwyn.
I've given you remote control. You can use your remote control.
Oh, okay, right. How's that? Doesn't seem to want to go, Bronwyn. Oh, here we go. Sorry, now I've gone too many steps. Was that me? Sorry, okay, right. So an eligible person, the criteria to meet MACNI eligibility is that you need to be over the age of 16. You need to appear to satisfy 2 or more of the following criteria: that your client has a mental illness within the meaning of the Mental Health Act, has an acquired brain injury, or has an intellectual impairment or intellectual disability. Also, they need to have a severe substance dependence within the meaning of Section 5 of the Substance Dependency Treatment Act, and also exhibit violent or dangerous behaviour to themselves or others, and in need of intensive supervision that would help get them back on track. So that's the actual MACNI program. So summing that up, it's really about the very pointy end of complex cases, complex clients, but our program also is available in what we call a complex needs space. So way before you'd even get to a MACNI space, to help with consultation, to help care teams navigate a particular risk in a client, or understanding what their diagnosis is, or the referrals that need to happen to help support a plan moving forward for that person. Okay, I'm not quite sure that I did that, Bronwyn. Did you do that? Okay. So MACNI was, as I've already mentioned, it was developed to address a siloed approach to all these different support services doing their thing. MACNI is really all about pulling everyone together and having really robust, transparent conversations about what needs to happen, what's working, what's not working, to get a person's life back on track. There is also a panel that sits bi-monthly with all the main players in the Outer East, is where we're from, excuse me, in terms of directors, general managers, experienced mental health teams, to come together and brainstorm a complex client's case and issue to help it move forward. Bronwyn, I might get you to, I'm not quite sure that that slide worked again. It seems to be jumping back to you. Is that correct?
No, I don't have the control at the moment. You've still got it.
Oh, doesn't seem to want to.
It might have a slight delay.
Oh.
So you're on establishment and MACNI panels?
Yeah.
I don't know if I can. Oh, here you go. There you go.
Did you do that, or did I do that?
I don't know, but just keep going.
Okay, thank you. Okay, so the do's and don'ts of safety when working with complex clients. Obviously, what do we mean by the term complex versus simple? Really, when we're talking about complex clients, we're talking about a client that has multi-layered needs, complexities, issues. So, for example, that could be a client that has a mental health diagnosis, potentially along with an acquired brain injury or cognitive significant cognitive impairments, and they may be experiencing domestic violence, or they may have a history of homelessness, or also trauma that's been experienced by this person throughout their life.
Oh, now hang on. So I've got participants. Where's I know. Yeah.
Sorry, can I get you to? I'm not sure if that.
I think I've just got to say where I'm from.
Could you please mute yourselves? How's it going there, Susanna? Do you need help?
Yeah, I'm waiting to see if it changed slides. I'm ready for the next slide.
Okay, I'll try and do it. Is that right?
Thank you. Yeah, thanks. Okay, so I guess we came up with a bit of a do's and don'ts list when you're on the ground working with a complex client. The don'ts would be trying to problem solve on your own a situation with a complex client. Do not accept responsibility for a risk that's really not yours to sit with alone. Do not place yourself obviously at risk. If you're doing a shift where the risk is high with no support, you really need to know a safety plan around that, and we'll talk about that in the do's. Don't underestimate the potential of what could occur. And I guess what we mean by that is we talk about relationships as potentially helping to support your work with keeping you relatively safe and aware, but given someone with such complex issues, you should never really underestimate the possibility of something happening. Don't engage in a situation that you don't feel confident with. Always ask for help, and don't assume that the relationship you have with the client will always reduce that risk. Yeah, next slide, please. Thank you. So the do's, always consult with your manager around what the plan is to support this person. Always seek advice depending on what the situation is. So depending on, a client, I guess where we would start would be, who is your client? What do you know about this person? What's their diagnosis? What is your understanding of that diagnosis? How can you get more information to help understand what that means for that person and what that means for their needs? What has worked for that client in the past? What has not worked for that client in the past? So understanding risk is really understanding what is their behaviour trying to communicate, what are their warning signs, what are their triggers. So I guess a quick example of that would be, you know, in a care team, I guess, getting everyone to have those conversations around, well, what would be really important to have as a safety plan for someone that's requiring community access, for example. And we had a client that was triggered by mothers with babies in prams on a bus. That was a major trigger for him. We could tell the warning signs for him. His legs started to jump, his eyes started to twitch. So there was a whole safety plan put around not taking him at peak times of the day when mothers and babies would be with their babies on prams in buses. Understanding also for that client what he can do if he is feeling unsafe, and as a go-to strategy, which for this particular young man was to grab his headphones if he saw a mother with a baby in a pram on a bus and reach for his headphones, but also to talk to him about a code word with asking for a bottle of water for a staff person. So there was all these types of risk plans around what to do if there was warning signs that something was starting to unravel. It's also as much for a staff person as it is for the client. So the staff person also needs a safety plan around who would they contact in the immediate and how would they respond. So understanding that it's not your job to hold the risk, but that you have a plan in place, and it's a very clear plan to know who needs to be contacted with whatever the needs are of the client at the time. And as I said, the complex needs team are always here for support, for a consult, or to actually help coordinate care teams to work through some of these issues, work through any gaps that may be appearing with service delivery for a client. Next slide, please, Bronwyn. One of the commonly asked questions that we get is confidentiality versus risk. The rights of a client's confidentiality, it's very important to hold in mind, can be overridden if a client is demonstrating risk to themselves or others. So take-home messages, your safety is as important as the client's. Great, and that's really, I guess, that in a nutshell. If anybody has any questions, please feel free to.
Okay, I'm just going to share the Slido again because it looks like we've got a couple of questions. So I'm just going to bring that up and we're going to go to the Q&A. Would you like to answer these questions, please, Susanna?
Yeah, sure. So does the person need to meet all of the criteria you mentioned? So when we're talking about a MACNI referral, the multiple and complex needs referral, yes, a client would need to meet that criteria to get that service, and that is you've got to jump through a lot of hoops to get to that service. But we actually have what we call a complex needs space and a couple of other spaces in between before you get to MACNI, so that clients don't necessarily have to meet all that criteria. You could still put in a referral form to us and we would still help you all along the way to really, what we're trying to do is support someone's needs way before they even need to get to MACNI. So basically for us to pick that up, a client up, they need to have a few complexities going on, but you're always more than welcome to pick up the phone or shoot us an email, put in a referral and we'll discuss that with you. Number 2 question, who sits on the MACNI panel? The MACNI panel is comprised of the Director of Outer East for the department. We have, I guess, all the main players at the table. We'd have the Manager of EDFOS, we'd have Child Protection, we'd have the Head Directors of AOD, dual diagnosis. So we have all the service systems come around the table to help us work through a plan for a client that maybe is stuck, maybe there's no engagement and services are not sure which pathway to go, or there is no pathway and we need to be really creative in coming up with a plan. Okay, one more question. Sorry, Bronwyn, I'm conscious of your time. Would a person need to be diagnosed in relation to these complex issues to have access to these services? No, not necessarily, no. What we would do is we can support you with your clients if they're an NDIS participant, for example, and they don't have funds to, and they may require a neuropsych assessment to ascertain whether there's an intellectual disability or what you're thinking about. We can help provide brokerage, we can help provide direction with that to get you started. I hope that answers those questions. How long does a MACNI, sorry, one more question. How long does a MACNI wrap around package go for? MACNI can go for a good couple of years. In saying that, we can also actually ask for a review. It's very, very flexible. It is legislated program, but it is very flexible in terms of really supporting that person's needs on the ground. So it depends what that looks like. I hope that's answered.
Terrific, Susanna. And I'm assuming, I think it'd be good just to briefly talk about how does a, if I was working with somebody and I recognise that there's a real complexity, where would I start? What do I need to do?
Yeah, okay. Well, you could actually contact the complex needs team, and we would start to unpack with you maybe the pieces of the pie that you're missing. So whether, you know, you've got this complex person, but you're not quite sure of what their diagnosis is, that might be a starting place to work out who is this person? What do we know? What do we need to know? Who are the main players in their life? Who are the main practitioners or the relevant people in their life that we know? He's got an AOD support person over here. He may have an NDIS support coordinator. That you really need to pull together a team, a meeting, and we could help you support you to do that and start to work through the information on what we know and what we don't know.
Yeah, fantastic. That's exactly right. So making sure that you know who else is involved and getting people together to at least work out who's doing what and getting at least that bit of the puzzle in place first.
That's right. And if there is limited support in place to be able to sort of what we call care coordinator care team, our program can often support you with that for an amount of time, but we're very, very flexible. We don't just I guess either cut and run at this complexity, you know, at this pointy end of complexive cases. So,
and is there any alternative to MACNI?
So it's kind of, it is a little bit confusing. So MACNI is kind of the overarching program, but I didn't want to, given the time today, didn't want to kind of get too bogged down with explain, but we actually start in what we call a complex needs space. So you can call, you can put a referral in, and we would look at that case. And that person may have co-occurring mental illness with AOD issues, and we would help talk you through and do some consults, maybe once, twice, 3 times, whatever's necessary to get you in a direction to help you working out, oh, maybe we could, you know, it'd be helpful, beneficial to refer them to this service, or maybe this is something you haven't heard of that you could try. If that is not enough, then we could move you into what we call a pre-MACNI space. And that's where we can start to throw a little bit of money towards, if there's no other funding bodies involved, to help support getting someone's needs met. Way before we get to MACNI. So MACNI is a very difficult program. You really do need to, it's a very tight criteria, as I've shown you in the first couple of slides. We have we have one case at the moment in the Outer East, and it's taken time-wise, it's taken almost 2 years to get from A to Z in supporting this person, but we've covered every single life domain, if you can think about it in those terms, out of a psych unit into the community, into his own home, and all the things that had to be covered in during that time. Given this person's case, it was quite institutionalised, so there was a lot of relevant practitioners involved, helping with support plans, helping with a purpose in life, helping how to re-engage in the community in a safe way. So we had VicPol involved all the way along too.
Fabulous. Well, thank you so much for your time today, Susanna. It's been really helpful information, and I'm
Great.
sure that people participating today have found that really rich and valuable. So thank you.
Right. No worries. Thanks, everybody. Bye.
Now, Susanna segued nicely into our next presentation because she's mentioned that substance use and mental health are common co-occurring issues in complexity. And so I'd like to introduce you now to Gavin Foster, who's the Dual Diagnosis and Service Development Manager. He's also my manager for EMSCA, but he manages a range of teams, the Dual Diagnosis team, the FAPME team, the Forensic Mental Health Specialists, and yep, you can have remote access now, Gav. I'll let you take control. He's across a whole range of specialist services at Eastern Health Mental Health Program, and he's going to help you to know how to be a dual diagnosis clinician. Take it away, Gavin.
Thank you very much, Bronwyn. And look, I just want to start off by, it's always tricky, these Zoom presentations, but I do actually want to acknowledge that I am talking on the land of the Wurundjeri people of the Kulin Nation, and like to pay my respects to all Aboriginal people, elders past and present. So, I'm going to talk about what is
speaking.
the most common co-occurring mental health problem. And well, what I'm going to go out and say that is, no, I don't think I'm going out in too much of a limb to say that, and that's substance use and mental health. And really, I mean, it's been around for a little while in terms of talking about substance use and mental health. And so you would expect people coming to any services really that if they've got a mental health problem, there's anything from 30 to 70% chance, and maybe even higher, that they actually have a substance use issue. And look, and so that's research has been around for a little while actually, but look, I still get confirming bits of information around this. And so I know last week that there was the poll held at the start of this co-occurring issues explored workshop, and in that AOD was highlighted as kind of the most significant co-occurring concern with mental health issues. Also, there's been a really good Royal Commission submission report come out from VACCHO, which is, for those who may not know, the Victorian Aboriginal Community Controlled Health Organisation, the peak body for those services. And in that report, they've actually highlighted that 48% of workers in Aboriginal community controlled organisations believe that dual diagnosis is kind of one of the biggest issues confronting them in their work. So I continually get these pieces of confirming information. So if I'm moving right along, just to talk a little bit about co-occurring issues. Do I still have control, Bronwyn, or is it just that delay thing? Just waiting to see.
You should still have control. It says you've got control, but we had a problem last time.
Yeah.
I'll just double check.
Okay, cool. I'll just keep talking away because I've actually got a backup screen with slides on my on the other side here. So
here we go.
Well done. Thank you. I should have. Okay. So so coming back to what I was saying. So when we talk about co-occurring mental health and alcohol and drug issues in the state of Victoria, we generally talk about dual diagnosis. And the important thing to know about dual diagnosis is that dual diagnosis can actually mean any combination of physical or mental health problems. So you can actually have a broken leg and have diabetes, and you've actually got a dual diagnosis. Or you can have asthma and depression. That would be a valid description. But however, in Victoria, what we've actually gone with is when we talk about dual diagnosis, we actually describe it as co-occurring mental health and alcohol and drug issues. But there's lots of different ways of actually saying dual diagnosis. Comorbidity is the nationally preferred term. There is also things like coexisting, co-presenting, what other, can co-occurring, obviously. And I'm just waiting for the slide to keep working. Yeah, oh, there we go. But my description of it, if you like, is that this is it's a fad that never fades. And I describe it as the fad that never fades because as much as services actually try to focus on alcohol and drugs, as much as they try and focus on mental health, the people coming to our service, they actually don't differentiate. They will come with both, like they will come with many other things, and that we and so for me, and it keeps coming back. So as much as services try to hold their position on either side, an AOD or mental health, dual diagnosis keeps coming back as being a key issue for people. So sorry, I flicked ahead because of the delay. So one of the things that will focus on just in terms of saying this is that co-occurring, that's the focus of this workshop. So dual diagnosis, co-occurring issues, that's absolutely fine. So common comorbidities, I guess, and so this is where we talk about co-occurring, when we're talking about dual diagnosis, talking about co-occurring, co-presenting, well, we're actually...
Excuse me, I just have a question.
Sure.
Should we be able to see your slides that you are speaking to? Because I'm not seeing them and I'm getting a bit confused about where you're at in relation to what slides you're addressing.
Thank you.
You should be able to see the slides. They're up on this board and I can see them on the main screen.
I can see you, but I can't see the slides.
Oh, that's really
odd. I can see the speaker in both windows, but I can't see the slides.
Hit the very top of your iPad screen and something will drop down saying see shared screen and it'll come back for you.
Oh, fantastic. Thanks, Mel.
So hit the very top of the screen.
Yeah, there's different views that you can have.
Stop video participants. More.
Now you want to keep your video on.
Meetings. Raise hand. Disconnect audio.
Hang on.
I didn't do anything, but it just disappeared. That was the thing that
I... okay.
That's no good. Sorry about that, Vincent. It is still working for others.
Right, okay.
I have sent you the slideshow though, so you might want to have a look at that.
Well, I am, but when he changes the slides, I don't know that that's happened.
Okay. Yep. Keep going, Gav. Thanks, Vincent.
All right. Look, yes, it's technology. We're not winning with it today, so we're doing our best. So thanks everyone for being as patient as you are. So yes, I will keep talking. And as you can tell, I can talk underwater. So common comorbidities. So we've got lots of different types of alcohol and drug issues. We've got lots of different types of mental health problems. And in fact, we get new and emerging kind of drugs coming up as well. We get also reclassifications of mental health problems. And so it makes it quite a complicated world when we're actually talking about dual diagnosis. But the important thing to remember is that they can change. So a person might be diagnosed with one particular issue and then they might have a new mental health diagnosis. Their substance use might change. And so it's always really important to get a really good picture of what's happening for people with their mental health problems and their substance use problems. And it can, as I say, can be a very confusing picture. So, all right. Is that you controlling the slides? Thank you, Bronwyn. You're doing a great job. So, so the next one is really, so I've been around working in, this is my 14th year working in dual diagnosis actually. And the important thing about that is that I'm not stuck on kind of knowledge that's 14 years old, whilst I think that that's important and really important to keep carrying with us, and including there's also areas where it's continuing to grow or areas of different emphasis. So I get most of my up-to-date information these days from two places. One is the Dual Diagnosis Consumer and Care Advisory Council, and two is the one of the teams I manage, which is the Dual Diagnosis Service. And so with the Dual Diagnosis Consumer and Care Advisory Council, one of the things that they do, because they're people on that council with lived experience of dual diagnosis, so people with lived experience of mental health and alcohol and drug issues, there's a lot of wisdom that comes from that experience. And so they share with me messages around things that they think are really useful for services to know, and staff, so people with you, so people in this audience to know around working with people. And so one of the things that they'll actually say is they'll talk about think integrated. So they want, regardless of whichever service you work in, they really want people to actually just be thinking about mental health and alcohol and drug issues. And so Bronwyn, if you could just click the next uh, part, because the other information will come up. Thank you. So so and so they actually just we're also acknowledging that it's about stopping people from falling through the cracks, but actually in the end it's actually about pulling people out of the cracks, because so many people are stuck in between our services. So they're actually wanting to make sure we're doing that. They're also understanding that there's different solutions for different people, so there's just not the kind of one set of standard dual diagnosis solutions for everybody. And it's also about acknowledging that if we're not talking about dual diagnosis, then we're not giving people the opportunity to be aware. And so schizophrenia and cannabis is a really good example. Depression and alcohol, people often don't realize that it's actually kind of causing them problems in both areas. And as we say, it's the key to opening a door for more effective recovery. So that's really important. The other thing that that the council talks about is judgment. And this kind of makes me a little bit sad to say, but I kind of sat in a room with about 40 people with mental health problems or mental health experience of mental health issues. And they actually said to me that when they talk to people in different services, particularly sometimes mental health services, that they feel like they're judged when they're talking about their substance use. And for me, that's a bit of an issue. So they're very, very strong in actually saying, please don't judge. Please don't blame the person. It might be a hard conversation. And our judgment, our attitudes, our feelings about these things can come across over the phone or in person. And in fact, there's much greater opportunity to learn from people with dual diagnosis, often sometimes than what we can learn in books. And the really important message that they highlight, and you'll hear this again, is around considering the importance of the impact on consumers, carers and families as a whole group. Generally, our services, we see a snapshot of a person, whereas the families and carers, they see the whole person, and they see the whole person all the time. And so it's really important for us to make sure that we're providing a really inclusive picture. So the other part is that I mentioned the Eastern Dual Diagnosis Service, and one of the things that we've actually set up recently is this, in the last 2 years, is this dual diagnosis shared care clinician service, where we are now trying to demonstrate dual diagnosis practice, because there's lots of writings about dual diagnosis, there's lots of theory, but there's not a whole lot of evidence for actually how you do this work. And so what's been really important is that we've had some really key things reinforced for us in that work, where these clinicians are actually working with people who are part of the mental health service, who are receiving case management treatment and rehabilitation style treatment from our case management services. So engagement is one of the most important things around working with people. And that's what the team constantly tells me about, how important it is to get to know the person, to build trust, to work with the person and try and connect with the person at on their level. The other thing that they also describe in their work is how important it is to understand the person and understand where the person's coming from, if you actually really want to support that person to think about a different style of recovery for them. And in that too, it's about working to strengths and working to the person's strengths, working to the supports around them, working to the things that are really going to help the person. So understanding those. And then another really key thing is really appreciating the impact of trauma that can have. We talk about trauma-informed care. I tell you what, it's an area that we still need to do a lot of work on, all of us, and actually understanding and working in. And again, it's how important it is to involve families and carers where that's possible. And the interesting thing about this is that sometimes families and carers can be part of a substance use picture for a person. And in actually helping a person, we can actually help family members. And we've had examples where family members have gone and sought help for their own substance use issue as part of the experience of providing that support for a person with mental health and alcohol and drug problem. So if we go to the next slide. So what's important about all of these things that I've just mentioned is that they're well documented. There's nothing really new about them, but often it's stuff that we're not implementing in practice. And sometimes they can seem a bit nebulous when we just talk about them in that way. And so for me, what I just really wanted to highlight is that there are tools that we can use to help us um, work through each of these things that I've just spoken to. So we know about the stages of change. And the important thing about the stages of change is the stages of change is also for mental health and alcohol and drug issues. So sometimes people just see it as an alcohol and drug model, but actually it's a model for people with mental. In fact, the first time I learned about stages of change was about 20 years ago, and it was in relation to working with people with mental health issues. And engagement, and we talk about engagement, a lot of times what we hear is, oh, they're not ready to change, and so we're not going to, they're not ready to connect with our service, is what that means. In fact, that's what the dual diagnosis clinicians that I was talking about before. A lot of their work is in the pre-contemplation space, and then they actually support people to move to a position of contemplation. So just because a person's telling you they're not ready doesn't mean that you shouldn't be working with them. So engagement. So there's a tool for engagement. So there's the next one. And here's another useful tool, and really this is around understanding and things that we can actually understand. So it's really important to actually understand why people are making the decisions and doing the things that they're doing in life. And one of the tools that we have available for us, which helps us understand substance use, is the reasons for use scale. And there are lots of different reasons why people use substances, but certainly there's some really, it's really important in this space to actually understand why people with mental health problems use substances, because sometimes the reasons that we're telling them that the substances are no good are actually they're finding the substances are helpful for them. And maybe it's about calming anxiety. And in fact, one of the interesting things that we're finding in our work is that amphetamines for some people seem to have what we call this paradoxical effect, this opposite reaction, where they become something that helps calm a person or doesn't, or maybe even supports some of their motivation. And we know that clinically we use dexamphetamine as an amphetamine for treatment for people with ADHD. And so, so I think that these are important things about understanding why a person is actually using substances. Simple one, alcohol and trying to calm anxiety is another really good example. Sometimes people are just using substances to fit in. And so it's really important to actually understand why people are using substances before we try and remove it from them. So it's about understanding the person. So the next one is really about that. This has been a conversation that I mentioned, the Dual Diagnosis Consumer and Care Advisory Council before. Well, we started to have a bit of a conversation about recovery. And Bronwyn, if you can just flick through the various points. So we started to have a conversation about recovery. And so it was from a clinician perspective. And we had these new recovery models and we wanted to talk about them. And the council members kind of at that time said, sure, you can talk about recovery, but what's the point about talking about that if you can't stop us from relapsing, if you can't help us there? And so then I kind of like, it was a bit of a light bulb moment, and we said, well, let's have a chat about what relapse prevention looks like for you. And so everyone was agreeing that was a good idea. So we co-developed this plan for mental health and substance use concerns. And basically, it is strengths-based. It is looking at every step of the way around what strengths does a person have around them for when things are going okay, for when they're starting to struggle a little bit, and then also for when they're in crisis. And we forget that when a person's in crisis, they've still got strengths, they've still got things around them that might be helpful. And sometimes we just need to remind them of that. So that's really important. So the next slide is around trauma. And trauma is a really big area, I think, for all of us to just grow in terms of our knowledge and skill. And trauma is absolutely a huge one in the dual diagnosis area. It's huge in the AOD area, huge in the mental health area. We know that it's a significant kind of part of the discussion for Aboriginal and Torres Strait Islander people, particularly talking about intergenerational trauma. So if you're not acknowledging the existence of trauma in the picture for a person where substance use is an issue, then you're going to have a really hard time actually addressing the substance use issue, because for a lot of people, the substance may be something that's supporting them to manage aspects of trauma for them, and it may be clouding it for them. And if we start to remove the substance too quickly without addressing and acknowledging that there's something around trauma, then we actually can make things worse for people because we've taken away something that's helping them. But we do need to take it away because we do need to support them to actually help manage better, or we do need to certainly reduce the amount that they're using, because what's actually effectively happening is that on top of their trauma, they're actually picking up another significant problem. And so we need to be able to address that. So there are lots of really good resources. The Matilda Centre in New South Wales has actually come up with some good resources. I like this one particularly. It's just a new one I've seen, and I like to kind of highlight anything new that I think is really good. And it's got some really good practical ideas in there. Yeah, so acknowledge the trauma, really, really important. The next slide, please. So this one is really around that whole working with the person's system. And I talked about having the snapshot. Well, often if our services, unfortunately, a lot of them are designed just to work with the individual. And whilst we talk about the importance of families, we're still not clear often at times on how to best do that. And I don't want to say that for everybody. I know that there's probably some of you who do this work really well, but from what I keep hearing around the track, it's a piece of work that we need to improve upon. So this is just a really nice model for talking about what the ideal should actually look like in this space, and around that if we're working really well, a clinician is often visiting a long-standing relationship between a family, carer, community that a person's actually connected. And so when we're working really well, we're actually working all together and communicating and involving each other in the discussions. And we need to just appreciate that dual diagnosis still is not widely known out there in the community as dual diagnosis, and people are still struggling, whether it's AOD or mental health. And so families and carers, support people, they all need information and education as well, because often they might be doing things that may or may not be helping, and they may be just becoming continually frustrated with services. So it's really important. So move to this. This is just for me, before we move into having a go at some scenarios, is just an important empathy mantra that, and so when individuals with mental illness and substance use problems are not following recommendations, they're actually doing their job. They're doing their job. They're managing the situation as best as they can. And their job involves coming to terms with the painful reality of having both a mental illness and a substance use disorder, wanting neither one, yet having to build an identity that involves treatment for both. And what's our job? So, Bronwyn, if you can flick that, please. So our job is to understand their job, to join them in it, and to help them do it better. I think that this for me is just a really beautiful quote around how we can work better with people in the area of substance use and mental health problems.
Welcome back, folks. I'm going to hand back to Gavin now, and he's going to run through the cases with you, and we're going to ask our facilitators to provide some feedback.
Okay, so thank you for that, Bronwyn. So hopefully you've had an opportunity to have a discussion about the three scenarios, and we're going to ask the facilitators for each scenario to report back. But just so that we know, the first one that we're reporting back on is around Karen, and there's some information around here that she's 38 years old and uses cannabis and has been disorganised and with having schizoaffective disorder, and has 2 children and accommodation at risk. So, and we've got a couple of questions, and the first question this group were actually answering was, why is it difficult for our services to help people like Karen who present with co-occurring mental health and substance use problems, and how can we make it easier for Karen to receive the help she needs? So who was a facilitator for that group? And I'd like to invite Peter. Fantastic.
Peter, all right, great. So how long have I got, Gavin?
About
a couple of
1
minutes.
minute. Yeah,
1 minute.
a couple of minutes.
All right, great. So look, great questions. We had a really good group that threw in a whole lot of ideas. We pointed out some issues and some solutions. But one of the reasons is that we don't have a one-stop shop that's going to address housing, family services, substance use, mental health. So one of the difficulties is that we can't do everything. So it's finding
Yep.
out what we can do, what our role is.
Yep.
We were pretty big on engagement and understanding her substance use. So we weren't
Yep.
keen to, we wanted to know, how does that help her? How
Yep.
does it benefit her? We wanted to know if the accommodation was at risk. That's going to be another
Yep.
problem for us as services. If she starts moving around,
Yep.
then it's going to be hard for us to keep track of her and keep engaging with her when she's on the when she's moving around. So the question is, can we be more flexible with our interventions? What can our services do to accommodate her needs? Denise was with us, carer, so we talked about the issues of family.
Yep.
Is DHS involved? Is there a link between the substance use and the child protection, if there is anything there?
Yep.
And just helping her just really to be able to engage with us and attend the service when she's irritable and not happy.
Fantastic. That's an excellent summary. Thanks for that, Peter. And I know that we've had somebody else answering that question in another group. Have we had somebody else talking to Karen?
That'll be me, Gavin. Sorry.
Oh, cool. That's all right, Ruben.
Look, Peter's sort of covered almost everything that we would have touched on anyway, but we were sort of predominantly talking about the idea that we have very siloed services. So, most services have obviously got a very, very specific focus,
Yep.
and the communication between those services is not always fantastic.
Yep.
Also, the stigma attached to these two particular diagnoses is quite significant.
Yes.
And then the impact that it has for people coming forward, discussing things,
Yep.
and what that looks like, even with communication between different services as well.
Yep.
So I think that's the only stuff we could add to what what's already been touched upon.
Very good, excellent. So sounds like some good conversations there. And I did mean to say, as part of this too, if people have questions coming up for them throughout this, make sure you put those onto Slido as well. So thank you very much for that, Ruben. So we might move to the next scenario, which was Michael. And Michael, there was a bit more information with him in around his substance use and how he's presenting, and in terms of periods around his psychosis too, and hospitalisation. Not having any money, and we know that he's got GPs and things like that. So, and that he also kind of occasionally steals to buy money for drugs, to get money for drugs. So we had a couple of questions there for. Sorry, move back. We had a couple of questions there for around Michael, and one of those: what are the common assumptions made in our services about people like Michael who use drugs and alcohol and have mental health problems, and what can we do to ensure that these common assumptions don't act as barriers to Michael getting the help he needs? So, who was facilitating that group? Who'd love to report back, please?
That would be me.
I can do that.
And
oh, sorry, Tom.
Do you want to go first, Rose?
Okay,
You can
Rose.
go.
Yep. Rose, I'm happy.
Oh, okay.
Yep, go for it. Thank you.
Yeah, thank you. And so some of the common assumptions that we came with is about not wanting recovery.
Yep.
Yeah. Nothing can be done about Michael, and that's who he is.
Yeah.
Or it's too late for any support to be put into place. He's the problem and not the drugs.
Yep.
He's a difficult client, and he's attention seeking, especially with the history of suicide attempt.
Yep.
And then, so when we went to question 2, how can services engage with him to not create barrier for him seeking support?
Yep.
So we came out as engaging with him and building rapport or trust.
Yep.
Connecting with him in all levels, and not to come in like a therapeutic way at first, and not to say to him, these are the services that we can refer you to, or these are the supports in the community that you can get. Just getting to know history of Michael and how he got, how did he get to this stage where he is at the moment.
Yep.
Just working in the background without putting in any kind of services. And what kind of other supports has he got in his life? Also being non-judgmental in working with Michael.
Yep.
So to not judge his drug behavior, not to judge his, stealing behavior, and, not being changing GPs from one to another. So just to work with him in a ground level to get him to a comfortable stage where he can be supported better.
Yep.
And also we talked about, so Karen in my group spoke about when to get to that stage where Michael is ready maybe to engage with services, is having to use motivational interviewing, therapy, or like narrative therapy, to get him, you know, to talk about himself and stuff like that, to get to that stage.
Fantastic. So that's another great conversation, and I really like the fact that you've highlighted the judgment issue that can occur for us in the start of that, and then working through that. So I think that was fantastic. Thank you, Rose. I'm just wanting to. I've missed a group in relation to Karen. So Kate, I invite you, Kate, just to so that we can finish off with Karen as well before we move back.
No, that's okay. It was everything else had been mentioned. Really, it was just that particularly good point I wanted to raise.
Or medication, that a multi-drug user may be aggressive, or have high risk, that his on and off again relationship is related to the drug use. So lots of assumptions often get made. Again, we boiled it down to getting to know Michael. And then perhaps the history and context will come after. Rather than diving in to really kind of dig around and get ask questions based off assumptions, I guess.
Absolutely. So really kind of focusing on that engagement and understanding side of things and working with Michael. So fantastic. Thank you, Tom. Was there anybody else who had Michael? No? Okay, excellent. All right. Come back. So for the next scenario, we had Aaron, and this is where we had a lot more information to work through. I feel a little bit sorry for this group. So with Aaron, we had some questions here about what should our integrated mental health and alcohol and drug response look like to Aaron and his family? And what can we do to ensure that everyone in this scenario feels included in the response? So who would like to talk to Aaron, please?
Hi, Anna Macris here. How are you going?
Yeah, g'day, Anna.
Look, in our group, we had a couple of workers from Gateways in Croydon, which provides the accommodation, crisis accommodation. So look, some of the things we looked at was obviously, starting point is where we can, if we can try and engage all the, with Aaron and his family, because at this point in time he's still living at home, which we thought was a positive and a strength. And really trying to get a sense of, what information do they know in terms of, what the awareness is. Is Aaron aware of, what he's using and the impact it's having on him? Are the parents aware? How much, again, being respectful of confidentiality, how much do they want to work together? We sort of looked at, giving them even just an education. So just keeping a very education-based information about the different drugs and the impacts that it could be having. Obviously looking at some of the practical areas, what does, what's Aaron's awareness, but what does he actually even, want to work on? Does he even want to work on anything? Where is he at in terms of the change cycle at all? So the idea would be to try and engage all three, and then also to look at, are there any supports? Because it could be that the parents also need their own supports individually to try and better manage him, and where possible to maintain him at home. We also looked at, are there any risks to the siblings? So from a child safety framework perspective, we looked at that. So obviously the awareness situation. I guess how to include everyone is, how, what's the best way to build that rapport and trust? Keeping in mind, who is our key customer? Look, supporting the parents. What's their response? What's their expectations in terms of Aaron remaining at home and understanding around that? Obviously, we talked about the protective concerns and risks, and look, where possible, the ideal is to have that holistic family intervention and engagement, because he's a young person and he's still living at home. And getting a bit of an idea of, again, strengths-based perspective, you know, how is the drug helping him? You know, how is it helping him? What are the tricks? What else does he want to be doing? Does he have any other hobbies because he's not engaged in school or work at the moment?
Yep, fantastic. That's a great. So I think with that scenario, we've covered off all those because you've talked about strengths, you've talked about family inclusion in there as well. So I think that's a wonderful conversation. Thank you, Anna. Did we have anybody else talking about Aaron?
We talked about Aaron too, so we wanted to dig a little bit deeper as far as what his presentation was actually referring to at the moment. Is it a first episode? Is it a drug induced? He needs further assessment and a bit more engagement. We talked about the family dynamics too, but we touched on that consent piece and including the holistic approach with the family and supports, etc. And there was some reflection in the group around this is a common story. This is one we've heard before, either personally or professionally. And the dilemma that with confidentiality, but also including those supports around people because they will be the ongoing supports. If they don't have support and they burn out, then it's incredibly difficult to support the individual. And how we've come as a service provision team to not just looking at the individual, but looking at the broader spectrum and support services, that's been a real progression. And that dilemma we have around confidentiality and how that plays.
Absolutely. Thank you for that, Fiona. So I think and that confidentiality one, it's one that the Dual Diagnosis Consumer and Care Advisory Council support, but feel like all services actually need to negotiate so that everyone can be involved. So that's a great point to highlight as well. And look, just to let you know, all of those scenarios, they're all made up, but they're actually all very, very similar. I expect you will all know to people that we potentially have all worked with. So they're bits and pieces of people that I've been aware of over the years, if you like. So thank you for that. I think that we might only have about 1 minute for any questions. Is that right, Bronwyn?
Yeah, it's fine. If we've got a couple of questions and people, can we get the Slido up, please, Matt? And if anybody really just wants to jump in with a question, that's okay after Gavin's answered these two.
Okay, so will the reasons for use scale document be available? Well, it's a widely available document actually. So it's easy to find. So we've actually got it as a regular form within our service. You just need to actually Google it, and you'll get a copy of it. It's a freely available form.
I think it's on the Nexus website, St V's Nexus.
St V's Nexus website. Yep. Under 18s, do you need their consent or their parents? This is a really good question, and it kind of really starts from when young people get to about 16 that we start having these conversations, really. Best practice is always to talk with the young person to get their consent, but obviously, via the law, if there are big decisions that need to be made that are around the safety or well-being, then as far as I know at this point in time, parents still have that decision-making capacity at up until 18. But however, you should always be talking to the young person as much as possible, particularly from about 16, even younger. It's all just really about how you explain it to them. As much as possible, they need to be on board with the sharing. And it's really often that stuff about making sure that we're not sharing anything that the young person doesn't really want shared, unless it's about risk to themselves or others, where everything just overrides any kind of consent kind of conversation.
Thank you, Gavin. Do we have any final questions that people wanted to ask that couldn't get on the Slido? Okay, looks like everyone might be ready for a break, Gav.
Good, excellent.
Oh, hang on, there's one more. We better get that.
Can you use motivational interview therapy with someone under 18 without involving their family? So motivational interviewing is really a set of techniques these days that you can use for really, as long as a person actually is in a position to understand what the conversation that you're having to them, and as long as you're explaining it to them, it's really about measuring, I guess, how, there are some 20-year-olds who are still quite young in their thinking. There'll be some 14-year-olds who are quite advanced. And so it's really about understanding the person that you're working with. And yes, you can have a motivational interviewing conversation with that person. It's got to do with where they're at, I guess, developmentally.
Terrific. Thank you so much for that. All right. So let's launch into autism and mental health. I just want to introduce you to James Shelley, who wasn't able to be with us today, but he's here virtually as a recording. And he's a child and adolescent psychiatrist with Eastern Health's neurodevelopmental assessment team, as well as the Box Hill Community KIMS team, or Child and Youth Mental Health. James will deliver a brief talk on the intersection of autism spectrum disorder and other mental health disorders, and he's going to provide some case scenarios that we can discuss. As he's unable to attend today, we've got Tanya Curlis, who's kindly agreed to support the workshop by facilitating the discussions and answering your questions. Tanya is the Clinical Director for Clarable, an NDIS support service. Tanya has a background in social work, change management and leadership, and her interest in co-occurring autism and mental health stems from lived experience. In 2014 to 2015, Tanya led a disability workforce culture change project for statewide autistic service, SASSI, across 9 sites to embed person-centred behaviour support systems for people with high needs, which resulted in a 70% reduction in behaviours of concern. So she's done some great stuff. Welcome, James. Now he's going to share with you his presentation, and then we'll have Tanya helping us in the breakouts. Thank you, Matt.
All right, good morning, everybody. My name's James Shelley, and I'm a child and adolescent psychiatrist with the neurodevelopmental assessment team at Eastern Health. And I've been asked, I suppose, in that capacity to talk to you today about autism and mental health. It's a huge topic, so I'll do my best to try sort of encapsulate it in a brief time. So what we'll cover today is I'll start just talking a little bit about ASD itself, the symptoms, the impairments, the diagnostic criteria, and I will make clear later why I'm spending some time focusing on that. We'll talk about the common comorbidities that occur in terms predominantly of mental health difficulties, but also sort of other associated features and challenging behaviors. And then we'll talk a little bit about sort of models of mental health as a segue into, I guess, thinking about this intersection between autism and mental health. And then there are a few case studies and questions for discussion within groups. So autism spectrum disorder, ASD, is a neurodevelopmental disorder. So, of course, that means it develops during or occurs during the developmental period of somebody's life, or at least it represents a collection of impairments in development during that particular period. And it's really defined by 2 domains of symptoms, the one being impairments in social communication and social interactions, and the other being restricted, repetitive, and stereotyped interests, activities, and behavior. So those are a bit of a mouthful. So we'll go through kind of sort of precisely what that means. And as I said before, to sort of clarify why that's important, I think to begin to think about, if we understand the impairments and how they occur, then to think about how might those impairments make somebody vulnerable to the development of a mental health disorder. So domain A, impairments in social communication and social interactions. So there are 3 criteria in this section. First is deficits in social emotional reciprocity. So this is, we break this down into social approach and conversation, sharing of interest and emotion, initiation and response to social interactions. So this really is about, I guess, the ease and flow and I guess the ease and flow with which somebody kind of initiates and engages in some sort of social exchange. So it's around conventional greeting rituals, social smile, a wave, a handshake. It's around kind of easing into social chat, talking about the weather or talking about something that's not a particular area of interest. It's not a highly intellectual, sophisticated conversation. It's just a little bit of banter, social chat, being polite, bouncing ideas back and forth. It's about sort of responding to social presses, I guess, in conversations and exchanges. It's a large part of what we intuitively think of as somebody's social skills. The second criterion then is deficits in non-verbal communicative behavior. And they often talk about sort of what they call a compensatory non-verbal communicative behavior. So it's not just about your non-verbal communication and, you know, in terms of eye contact and facial expressions and gestures and body language, but it's also about how well that is integrated with the verbal and non-verbal. So if you say you're happy, do you look happy at the same time? It's also about how well that is matched with the intensity. So if something small happens that you know it would typically make anybody a little bit upset, is that small amount of upset expressed in a proportionate manner, or is it completely exaggerated, or a big upset, is there kind of an absence of expression? And it's really about, this idea of using non-verbal communication as an adjunct to the verbal communication that we use, and as more of a social tool. And then the third domain, A criterion there, is deficits in developing and maintaining peer relationships. And so this is about interest in peers, initiation and response to play and to other interactions with peers. It's about sort of negotiating, I guess, the complex dynamics of group play in terms of adopting different roles, negotiating, turn taking, those sorts of things. It's also about sort of flexibility in play, in terms of, or not so much flexibility in play, but kind of using sort of symbolism and imaginative play. So being able to put yourself in somebody else's perspective. You have to kind of have a sense that another person has their own mental and emotional state in order to pretend to be like that person. And then as we grow older, it's also about adjusting to social context. So expressing slightly different sides of yourself when you're with your friends versus, sort of contextualizing your behavior between your peers, your teachers, your siblings, your parents, other professionals. It's about understanding the concept and understanding how you might sort of adjust and adapt according to who you're interacting with. So for the diagnosis, all three of those domain A criteria need to be met. And then the domain B criteria consists of four. The domain B consists of four criteria. The first is stereotyped or repetitive motor mannerisms, speech, or use of objects. So that's really the focus there is on repetition. So motor mannerisms like ticks or blinks or clicking or clapping or flapping. Repetitive language, so repeating a particular phrase from their favorite movie or TV show, or listening to the same song on repeat or the same TV show on repeat, or echo phenomena, so repeating the last word of one's own sentence, or perhaps repeating the last word of your sentence before I respond to you, that sort of thing. And then repetitive use of objects. So this is really about, particularly for children, it's about looking at their play in detail, and not so much do they play with the same thing again and again, but is there an element of repetition within the play and sort of non-functional use of toys. So for example, using a toy car and just spending all the time opening and closing the door, or spending all the time spinning the wheel, as opposed to actually playing with the car as if there was a person in the car, etc. Then the second criterion there is insistence on sameness and inflexible adherence to specific non-functional routines or rituals. So this is really about rigidity in thinking. It's about certain things needing to be done in a particular way, in a particular order, or done according to one's own sort of particular kind of framework or blueprint. it's about, you know, for example, people need to sit at exactly the same place at the dinner table every night, or food needs to be dished out in a particular way, and the different food items need to be kept separate from each other, or there needs to be a particular order in which someone gets dressed or does the bathroom, you know, like brushing teeth and that sort of routine. It also talks about kind of difficulty with changes. So small, you know, changes in plans or environmental changes, the pictures on the walls or the furniture in the house. And then it's also as one's cognition develops, becomes more conceptual. So it's, you know, kind of becomes around a sort of preoccupation with rules, fairness, justice. People can sometimes become quite pedantic with language. You know, they'll often end up sort of correcting people a lot, or people, you know, picking out when people have said something that's slightly incorrect. So it's really about that kind of rigid manner of thinking. Then the third one there is restricted patterns of interest, which are abnormal in intensity of focus. So this is, I mean, this is sometimes about the content of focus being unusual. So somebody might be interested in ceiling fans, and they know all the models and brand names of ceiling fans and all the control modules and so on, which is, I guess, unusual unless your family is in the ceiling fan business. But it's also really about the intensity of focus. So it could be a normal thing or a typical thing to be interested in, but the child might spend all day interested in it. So I don't know, Harry Potter is a popular sort of topic. It's pretty normal for kids to be, you know, go through a Harry Potter phase. But when it's reading their books on repeat, watching all the movies on repeat, you know, spending all day on websites with all various Harry Potter trivia and dressing up and doing one battles or whatever it is, and when it takes up all your time to the detriment of other areas of focus in your life, then it becomes a problem. And then the fourth one is about sensory phenomena, so hyper or hyporeactivity to sensory input. So either sensory interests, engaging in more sensory activity. So again, things like clapping, flapping, spinning, jumping, pressure, climbing into tight spaces, liking the particular sound or a particular smell or a sensation on the skin, or a sensory sensitivity, so being particularly sensitive to sound and noise, particular sounds or just busy environments or loud noises, particular kinds of light, particular touch on the skin, only wearing certain materials, or insisting that the labels get taken off. Perhaps sensitivity to particular textures of food is often a problem. You know, that children might not like, I don't know, sort of runny, saucy, sloppy kind of food. So no soups, no curries, no stews. Has to all be clean and separate. So it's yeah, kind of along those lines. Now, when you look at domain B, you need 2 of those 4 criteria. So for the diagnosis, you need 3 domain A and 2 domain B. Now, the most common comorbidities that occur with ASD are that first cluster there, the other neurodevelopmental disorders. So it's, you know, it's good practice when you make an ASD diagnosis to ask yourself, are there other neurodevelopmental disorders present? And the most common one there is ADHD. And then there's also intellectual disability, and you know, some of the others that you can see there. And more often than not, that would be sort of teased out in a broader, more comprehensive developmental assessment. The mental health disorders that are most commonly associated with ASD are, I guess, the most common ones anyway. But so depression, anxiety, schizophrenia, those are the sort of the major ones. We also find there's a strong association with feeding or eating disorders, and there's an increasing literature on the association with gender dysphoria. There are some physical health comorbidities that commonly occur, such as epilepsy, specific genetic syndromes, and then some just associated challenging behaviors that don't necessarily warrant diagnoses on their own, but that there's an increasing literature on the concept of ASD-related anxiety that doesn't fit into the generalized anxiety or other anxiety disorders. Personality pathology can pose a particular problem. Attachment difficulties, motor incoordination, executive functioning deficits. So executive functioning is around sort of complex planning, I guess, being able to sort of make a list of a multitask process or multi-stage process to enact the required action, to analyze one's action and adapt the plan accordingly. So those are kind of the major comorbidities that occur. Now, I thought it'd be interesting. I thought it's a good idea to sort of touch on this idea of models of mental health in coming to thinking about the intersection of ASD and mental health problems. So one of the common models within mental health care is that of the biopsychosocial model. That's probably, it won't be a new concept to anybody, but it's the idea that mental health disorders arise out of the interplay of biological, psychological, and social factors. And attached, I guess, similar to that model is the stress diathesis model, that mental health problems arise when a person with a specific set of vulnerabilities experiences a stressful life event. And I think that's particularly pertinent in this discussion. If we consider not just ASD as a broad concept to be a vulnerability, but if we think about the particular diagnostic criteria and the particular profile of impairments and difficulties experienced by people with ASD, it helps us to better understand what that pathway is to a mental health disorder arising, given a specific stressful life event or given the stress that arises as a consequence of those impairments. So I thought it's kind of useful to sort of break it into that biopsychosocial thing, to think about that, because it really helps to inform the intervention you're able to offer if you have a detailed understanding of why this young person with autism is presenting with this particular mental health problem at this particular time. What's been the pathway? So if we think about biological factors, think about genetics, we know ASD is a genetically or biologically based, genetically based condition. But there's a lot of heterogeneity, so that means there's no one single gene. There are many genes and many combinations that could lead somebody to express the particular kind of phenotype. And it's a concept of differential liability. So for the sake of example here, let's say you needed 10 particular genes to be able to express the problems with ASD. It could be that mum has 5 and dad has a different 5, and neither 5 on their own is enough for mum or dad to have ASD, but that right or just wrong combination would lead to the difficulties. And so I suppose it's important then in taking the history, not just to ask about is there autism in the family, but to ask sort of more detailed questions. Were there learning difficulties? Were there elements of ADHD that maybe weren't diagnosed in one or other side of the family? And it helps, it can help piece together just exactly sort of what we're dealing with in the young person. On a psychological level, if you think about cognitive and neuropsych factors, so I mentioned already, things like ADHD are more common in ASD. Intellectual disabilities occur more commonly than in the general population. I mentioned before around executive functioning deficits. So even if somebody doesn't have kind of a broad sort of doesn't have sort of an intellectual disability or a global developmental delay, there might be specific domains of their cognitive functioning that might be sort of discrepant, or they might not have a flat profile that could cause problems for them in their learning and their interactions with other people, that could lead down the line to the development of mental health difficulties. Um, the social relational factors. So of course you can understand how if it's difficult to interact with people, it's difficult to socialize, it's difficult to make sense of other people's mental states and emotions, it's difficult to initiate and maintain social relationships. You can see how that could make somebody vulnerable to sort of social marginalization. You can see how that would lead someone down the stream of development of poor sense of self and self-worth and self-esteem, and how that could make somebody vulnerable to social anxiety, to generalized anxiety, to depression. The rigidity in thinking, I'm sure you can imagine how um, everybody to some extent in our lives needs some sort of structure. We need some sort of boundaries. And when things don't fit in with our particular viewpoint or our particular blueprint, it can be a little bit distressing for us. But for most people, we're able to adapt. We're able to sit with a certain level of uncertainty. We're able to employ some flexibility in our thinking. But if you're particularly rigid, it will be particularly distressing for you when things don't fit within your particular frame. And that can lead to an increase in stress. And then concepts around identity, personality, even attachment concepts. But you can imagine how we form our identity and we consolidate our identity and our personality through reciprocal social interactions with others in our environment. Initially it's with our direct family, then it's with our peers, then it's with the world at large. And if you struggle to make sense of people on a social level, if you struggle to have sort of consistent, long-standing relationships, if you struggle with flexibility in your thinking and struggle with thinking about abstract concepts like values, you can see how it might be difficult to form a sense of identity and a sense of who am I, and who am I compared to other people, and how do I fit into the world at large. And that area poses a particular problem in mental health, that intersection between ASD and personality pathology. And then just touching briefly on the social aspects, so social environment, the physical environment, society and culture. I guess this is an extension in large part from the psychological ones, but when you think about somebody's environment, their social environment, the personality and character factors, temperamental factors of their family, of their friends, and their environment more broadly speaking, the culture of the society within which they live, the financial position, the sort of political framework within which they live. One can sort of start to understand how different cultures and different societies and different social environments would have a different impact on somebody with autism and their understanding of how to engage in their social environment, and how that might increase this, may be protective, but may also increase their stress in managing themselves and their mental health. I'm just aware of time then, and so we're going to move on to the case studies. So thank you for listening. I hope it's been helpful, and I hope the case studies and the questions allow for some further interesting thinking and discussion. And I'd be happy for anybody to contact me via email if there are particular questions or other topics that they'd like to discuss. All the best then. Bye-bye.
Hey, yes, could we pop questions into Slido if we have them for Tanya around ASD based on James Shelley's presentation today and also on our discussion? We'd like you to pop your questions into Slido at J300. If you are unable to use the Slido and you're really struggling, put them in the chat or pop out with them at the appropriate time after we've had our discussion. So if we can go back to the slideshow now, Matt. Thank you. All right. Go back a slide perhaps, or two. Yeah, that's it. Thank you. All right, we're going to have a bit of a discussion. I'm going to hand over to Tanya now.
Thanks, Bronwyn.
If you could just indicate all the facilitators, they'll pop in and give some comments.
Thanks, Bronwyn. Great to be here, everyone. And James had a fantastic presentation there. It was really helpful. I was just interested to pick up on, because I caught a little bit of both of the case examples. It was really fascinating, I think, James talking about ASD and youth in particular, and talking about how we might pick up on a diagnosis for a young person. And my specialisation tends to be working with people who are in young adulthood, who might actually have emerging mental health issues alongside their ASD diagnosis, or in adulthood where perhaps a lot of these themes haven't been well held in a range of ways, and they're late to all sorts of diagnoses. So, you know, feel free to pop questions in about any of those groups into Slido. And I'll just have a look at the chat here. So, yeah.
So Tanya, can we just ask the facilitators to feedback first? We're not at Q&A yet.
Yeah, great. So facilitators of group 1, who have we got?
Is that Rita? Is that the Rita case study?
So
I think it was John.
You might have had the Rita case
I think
study.
John was first.
John was first, okay.
So have we got someone from the first group? How many groups did we break into in the end, Bronwyn?
I think it would have been 7, but I wasn't controlling it, so I don't know.
Yeah, okay. So if we could start from, if group 1 would like to feedback, that would be great.
I think I might be group 1, but we had case study 2, which was Rita.
Oh, fantastic.
That's okay.
So we talked a little bit about, none of you will actually have any of that information as such, but she was diagnosed early at 7, but her parents didn't tell her that until she was quite older, around 14 or 15. She's now 16 and experiencing lots of difficulties around her identity. We talked a lot about that with the best of intentions, perhaps not wanting to add stigma and concern either for Rita or her parents. Maybe that's why the parents decided not to say anything, but the unintended consequences of that was really her not really understanding how her experience was playing out and why she was different. She was bullied at school. She wasn't accepted there. She had no personal acceptance for who her identity was and how she fits into the world. And that was starting to present with lots of emotional dysregulation and anger outbursts, and wanting to change her name and religion, and leading towards risk issues around depression and anxiety, self-harm, suicidality. So we talked a lot about that identity stuff, and that had she been aware early around why her experience was the way that it was, and why she was experiencing the world in the way that it was for her, that might have given her some context to feel like she could fit in or understand how things were going. We also thought that we wondered if there was any early intervention, given she was diagnosed early, and how that might have played out, but we didn't have any context around that either. But we really focused on that identity piece, really felt that that was the missing piece.
That's a really great comment, Fiona, and just picking up on themes of identity, and for women with ASD, it's particularly challenging to grasp identity, because a lot of the diagnostic approaches for assessment are designed around boys and men. And so often the ways in which autism is described to a person, to a woman who identifies or has been diagnosed as ASD, don't seem to be quite a fit. So we can talk about that a little bit later as well. I'd love to hear what group 2, whether they discussed John or Rita. Do we have someone from group 2?
I don't know what group we were in, but I wanted to add a comment about Rita. Hi, Tanya.
Hi.
I really liked how our group talked about the shame and the stigma being a part of that, both in the family sphere and maybe for Rita as well, as part of that identity forming. But we talked about parental education and support when we talked about how might we support and understand.
That's a really great pickup, and having worked in the carer space as well as the disability space, I can honestly say that up until about age 18, a lot of families identify as parent. They don't see themselves as carer, and they're reticent to acknowledge, because bringing those things up acknowledges their own grief and loss, and it's really, really complex to go there. So that that delay is also about a denial and thinking that maybe there's a fix and a cure if we put enough resources in, but just don't tell the child. So we see a lot of this, and what ends up happening is the young person will, potentially be dealing with the social limitations of their experience, and or of their neurological impairment, and then not explicitly have the tools to work with it. It's not overted enough for them to be able to make sense of their world, and so they problematize. The person might problematize themselves. I'm sure you've all worked with people who've had that unfortunate situation with a later diagnosis. Yeah, and parent support's really critical. There can always be more of that. Any other comments about the Rita?
Yeah, look, Anna Macris here. So look, in our group, we sort of covered all the things that were, that have already been discussed. But again, parental support, their awareness. But we also, we looked at, I guess, understanding Rita a little bit more, because, how do you establish that rapport and that trust with someone? And having a look at what are the strengths, what has been tried before, what's been effective before, and honing in on some of those, but also looking at what are some of the things that Rita enjoys. She enjoys reading, so that might be a good sort of entry point if she enjoys the reading. And keeping her connected was critical to the home, to parents. We didn't know whether she, what her thoughts were around school, given that she's had a bullying experience, but have there been some positive components of her being at school, positive engagement? Does she have friends that she's had positive experience with? So there was some of those social elements too that we probably would like to get a bit more information around.
Yeah, that's a really good pickup around just the context of what's been happening more broadly for her at the moment, and not just making sort of assumptions based on the information that's sitting there, and also the focus on a special interest, which is often it can be quite common, particularly for, all of us have unique interests that are our own and that connect us more to others, and it's easier to get a bit of buy-in with someone and build that trust when we focus on things that are of interest to them. But particularly so with ASD, we might find that there's a couple of specific things that give you a bit more buy-in more quickly. So that's a really great strategy.
And also because she's 16, so just the general sort of adolescent sort of developmental issues around self-identity, self-worth, peer groups, all of those things that would be, for everyone that's in that age group.
That's right, and they'd be much more complicated in terms of sometimes processing speed being a bit slower, and feeling as though I'd like to contribute to the group, but I'm actually jumping in at the wrong time, and they've actually moved on in the conversation before I got there. Or I'm fixated on this one topic and my friends don't want to engage in that topic anymore. We've done that for 3 weeks. So there's a lot of jarring mismatches in the social expectations in a person's capacity to fulfill the expectations of people around them. And that can lead to a lot of isolation. And I imagine if the diagnosis came late, perhaps to some self-loathing. Did anyone else want to talk about Rita, just since we're not really moving through the groups per se? And then we could move on to a discussion around John.
Yeah, sorry, there's not much time left. It looks like there was 4 groups doing Rita. So our little group, all we'd add to that is the idea maybe culturally, there may be a cultural overlay around shame and stigma of mental health that they might have wanted people not to know. So there's a bit more to explore, but also how it's not very affirming when it's not spoken about. So supporting the parents and understanding.
It does sound like there might be a reason for shame. Absolutely, yeah. And the cultural aspect's a really good pickup. Thanks, Peter.
Yeah, and so this is Rose. So in my group, we talked about having to connect in with Rita to understand her better, and as well as maybe getting to know if maybe she knew her condition earlier on, like growing up, knowing that, you know, this is who I am and this is the condition that I have, would have made any difference to now that she's 16. And so also going according to Rita's pace. So instead of having to pressure her to putting in sports and stuff like that, so work according to her pace. So easy pace or whichever pace she wants to go in through. So that's the pace that we would be using. And then the other thing we talked about, you know, using the family-centered approach to work with Rita for her to get to a stage where we can services can be put into place to support her.
Fantastic. And I was in your group, Rose.
Yeah.
And
anything that you want to add on, maybe?
Yeah, I think we did really well. Just in terms of, you did really well at conveying everything that we covered, and I think everyone's explored a lot of the common themes. If there's a book that you would like to look at in terms of understanding women and ASD, it's called Aspergirls by Rudy Simone, and it's a great short read, and it has a lovely table in there that outlines some typical mannerisms or ways of being that women with ASD identify as being slightly different to men with ASD, which can help you in relating to women and not making assumptions about how that is experienced for them. Sometimes they're emotionally attuned to the extreme, but just have difficulty distinguishing or articulating that. And then others might find it really difficult to work with emotion whatsoever and have a really flat affect. So it's important that we don't make assumptions just because of the diagnosis itself. Everyone is quite unique in how it presents for them. Yeah, thank you.
Thanks, Tanya. Can you just put that into the chat, the book?
Yeah.
Also, can we move along, because we've only got about 2 or 3 minutes left and we haven't done our Q&A. So
great. So
if we could just
some high-level points about John very
John,
quickly,
yeah.
perhaps 1 or 2 groups. Thank you.
Peter Fairbanks, did you have John?
No, a lot of us had Rita.
Okay, it
There's
must be
five of us had
Ruben
Rita.
and Kate. Kate, have you got some stuff to feedback about John?
We had Rita as well.
I think
Kate?
everyone had Rita in the end, Bronwyn. I had Rita as well.
That's odd. All right, well, we discussed, is anybody in the room that hasn't had Rita? Tom?
They had Rita as
We had
well.
Rita
You made
as
some
well.
comments.
Okie doke. I had John.
Do you want to chat about John, Bronwyn?
Lena and I talked about John, and what we came up with, we'll be very quick because we really need to move on, was that his social needs were not being met, which was probably leading to a major depressive episode because of the COVID situation. He was used to going out to a social discussion group, a gaming-based one, and he was unable to do that during COVID. And we were asked the question of, you know, how do we kind of manage or support him, and what would be needed to be considered around his ASD in relation to treating him for his major depression. And Lena was talking about the need for a psychologist or a good GP, and that engagement would be really critical, and whether the parents were actually able to manage at home, and that people might not be picking up on the depression because they might normalize that as part of his experience if he hasn't got a very reactive affect anyway. That might be because we don't know enough about John.
That's a great point. Yeah, I think, thank you, Bronwyn. I think too, just to pick up that it's often assumed that people who have ASD will be anxious or will be depressed, and therefore it might not be taken as seriously as it would be if it was a person ordinarily coming in for support around those things. And in a way, that's a lovely empathy that people assume that life might be difficult for them, but it might not be attended to diagnostically in an appropriate way. So that's really helpful to think that through in terms of, are we noticing a person's affect and then making assumptions around that, or do we check in with people appropriately and do the appropriate assessments? One of the things that I wanted to share about that, about both of the case examples, was have a look at when the diagnosis occurred. It can actually really, in terms of the actual diagnosis, not when the person was told, it can tell you a lot about the possible level of ASD. And even if you don't have the reports available to you,
it might assist you to conceptualize the level of intellect to some extent, and it won't be conclusive, but if a person's diagnosed at around age 8 or 7, by today's standards, that's quite late. If they were a level 3 ASD, which means more on the traditional flapping behaviours and toe walking and things that James was talking about as being extreme ASD, you might be seeing that present at age 2 or 3, and it might be picked up clinically much more quickly. So if someone is around 7 or 8, they might be a level 2 or even more at the Asperger's end, the level 1. So we don't use the term Asperger's anymore, but colloquially within the autism movement we do. And remember that it is actually an identity movement as much as it is a diagnosis. So there will be people who are very proud of their autism and really want to embrace that. And, you know, for those people, it's important that we speak to them in affirming language around, you know, how have you managed social situations so effectively to get this far? Strengths-based conversations and things like that can be really supportive, and acknowledging. So acknowledging the challenges, maybe not naming them as deficits. That language could be a little challenging, but clinically, of course, you know, in our case formulation and discussions, we might be discussing behind closed doors. These are some great questions coming through. I'll jump on in. Best way to support someone who's diagnosed with ASD as an adult? Thank you so much for that question. I've actually got a number of adults that I'm supporting in my clinic at the moment. And one of the first things I've noticed is that people still in this day and age receive a diagnosis without a walkthrough of what that means for them. So one of the things is to attend to grief and loss, if that presents at all, or confusion, or making sense of why has life been difficult for me. You know, perhaps they will actually admit that life has been difficult for them in a range of ways, and this is a bit of an epiphany and a release to feel as though there's some acknowledgement in a diagnosis. But I've found one of my clients has really appreciated walking through almost with a narrative reframing approach through the diagnosis piece by piece and working out what it means to her, actually determining together the language that we would use to describe so that she can use her own words to understand what exec function means, what receptive language means to her, and actually find some case examples of how that presents in her life. And then we actually build some social stories. So it happens really quite organically in the conversation that you know, you might hear, oh, that actually relates to when I get off the phone from my sister and she gets irritated because she says she's going to go and I say, okay, bye, and I hang up. And the small talk and the wind down isn't understood. So actually talking through, well, what could you say? Or how might you hold that? And do you understand why that's important to other people? And just supporting that and reflective capacity, I suppose. And bringing in a really empathic approach. In terms of defining the difference between anxiety as a clinical presentation and anxiety related to ASD, excuse me, I'd say they're both and the same. However, a way of determining the extent to which the ASD is the main feature or the anxiety is the main feature of what's happening, if that's the concern there, let's actually look at from a baseline what this person has been able to do across their life up until this point and determine when the anxiety hit. It's much harder with little children. You might see meltdowns and you might just see that the anxiety is occurring all over the place, and it's hard to tell because we haven't got a set pattern of how they're being in their life before the anxiety comes. But if it's an adult who had more of a steady ASD presentation with set routines and preferences, and you know, perhaps they were a little bit shut into their room, or perhaps they did have a friend or two in certain circumstances that they would interact with. What has changed? Have the friendships dropped off? Are they, you know, I've seen people who, for example, fixate as an older adult with ASD on the changing of the TV station on the right time and watching the Foxtel screen to see whether actually we click over from
the sports show over to the drama at 3 o'clock when the show said it was supposed to happen. So that fixation on transitions and things like that could be ASD related, but the anxiety linked to that links to the ASD versus being placed in a brand new situation where there's no social skills around it might be a different level of anxiety. Not sure if that answers the question. I'd love to open up to discussion if people are interested in exploring that one a bit more. Or happy to move on? No worries. I find most services are directed at children. Are there any services you are aware of that support adults? So in terms of diagnosis, and at last year's MSCA, we had the Victorian Dual Disability Service. So they would be a fantastic behavioural diagnostic point. They're situated at St Vincent's Hospital. So I can pop that into the chat. It's BDDS dot, I'll just put it down as the Victorian Dual Disability Service.
Last week we heard from Dr. Tarek.
Oh, great.
So
great.
they've met
around
Dr.
intellectual
Tarek?
Disability?
Yes, but the
Fantastic.
same service, yes.
Yeah, fantastic. So they would be a diagnostic point, hard to get into, but excellent behavioural recommendations. And I think it would be really great if a person could have that comprehensive support at the outset if there is true dual disability going on. In terms of services for ASD itself, there would be places like Aspect, Statewide Autistic Services. Amaze is the peak body. So you could always go to those large peak organisations. Tandem Mental Health Carer Peak organisation also supports people with ASD and their families to some extent. So they'd be some places to go to uncover what else is available. And at Clarabelle, we're a private practice and we do support those people as well. So I know a number of OTs and private practices that specialise. Yeah, so if anyone would like to email me later to find out services in a particular region, I'm always happy to suggest those things, or Bronwyn could connect us. What about high level of ASD? I'm not quite sure what the question is there. In terms of high function,
I'd imagine it's when there's a more extreme autism spectrum disorder. Oh, high functioning. Kate Close said high functioning. I would have thought a high level of ASD would be a high level of autism, as in, you know, at that end of the spectrum.
Yeah, so just in terms of maybe the politics around the naming, so in the most recent DSM, we've actually had it moved to level 1, 2 and 3. It might have even been there in the preceding, but traditionally it was ASD and then Asperger's syndrome, which has now been dropped off. So high functioning autism would be a level 2 in the current ways of describing things, diagnostic frame. And so what we'd be seeing there is a person who perhaps doesn't cope with having a job, managing transitions in their life as much, perhaps more heightened sensory challenges, but still able to hold a conversation, still having reasonable receptive language skills, even if it's a bit patchy at times, or if there's distractions, they're not able to attend quite as well. Whereas if you had level 3 autism, it might be accompanied by intellectual disability as well, typically, and you'd see more overt challenges in attending to social skills and connecting in with people. Yeah, so I hope that answers that question. But high functioning ASD, people can still live a very rich life. I know a lot of people with high functioning ASD and Asperger's who are married, who have children of their own, and often children with autism. And so it's possible to support people to manage their mental health symptoms alongside.
Thank you so much, Tanya. That's excellent. You've really fleshed that out so well for us. And I'm sure we've all learnt a great deal from the presentation and also from your additional support for that. So thank you.
Pleasure, thank you.
Thanks for taking the time to come and share that with us. It is a complex area for most of us clinicians and workers to understand, so really appreciate it.
Pleasure.
I'm going to wrap up now. So if we just go back to the slideshow and pop up the last 2 slides for me. Thanks, Matt. So I just want to acknowledge that this event was developed by the EMSCA Implementation Committee members, and most of them were here in the Zoom with us today as facilitators. We also want to acknowledge the webinar delivery was by live streaming services. Brad Every and today Matt has been assisting with that. And the executive producers at Eastern Health. So thank you to all our presenters. Thank you to all our participants. And just to remind you that you can go, I'll just change the slide there, Matt, that you can go to the Eastern Eastern Melbourne PHN website and you can find the EMSCA page there. And this recording will be substantially edited and then popped up on that web page in the next week. So I'll let you know when that happens by email. And please join us again next year. We'll be doing a collaborative care planning workshop in March. We've got a great big navigation forum in